Welcome back. We will now begin our afternoon sessions with public comments. To participate, select the raise hand feature located in the toolbar at the bottom of your screen. The host will then see that you have your hand raised and invite you to speak. Participants will have 3 minutes to provide public comments, and we ask that when providing the comments, you provide your name and organization. We will be selecting participants in the order the hands are being raised. So we will begin with Scott Moore.
Hello, my apologies. This took me a minute to get myself off of mute. Thank you for taking my comment. My name is Scott Moore. I am with Moore EMS Consulting and Moore Healthcare Law. I have been an EMT for over 33 years and a call firefighter, or served as a call firefighter in my hometown community of Topsfield, Massachusetts for over 18. I've also been an EMS attorney for over 20 years. My firm assists EMS and public safety clients with various issues impacting EMS organizations, but primarily we focus on the human resources and workforce challenges that are facing EMS organizations today. I first just want to thank the committee and its members for all of their hard work and efforts over the last few months. I know it has been incredibly challenging. I appreciate how complex and dynamic the factors are that impact balance billing with regard to the provision of ground ambulance services in this country, and we're all anxious to take the patient out of the middle. However, given the vast differences of EMS needs across the United States and the different urban, rural, and super rural communities that EMS agencies serve, I think it's going to be very difficult to develop one regulatory standard. So I simply just asked the committee to keep in mind the importance of local control of EMS in the regulatory arena. And then I asked the committee to also keep in mind the Supreme Court's sort of position that Congress cannot commandeer states' regulatory process by ordering states to enact or administer a federal regulatory program that restricts the state actors' control. So with that, I thank you.
Thank you, Scott. Next up, we have Randall
Strozek. It's Strozek.
Okay.
Thank you.
And if you can your organization and affiliation.
Sure. I am the president of the American Ambulance Association, as well as I am a member of the leadership team at Global Medical Response. I want to also pass on behalf of the AAA, our incredible appreciation to every member of this committee and to the staff who have spent months working on our process that we know is complex, but incredibly important for the continuation and stability of healthcare across the country. I also, support, and we want to reiterate Scott's comments that, that avoiding and cannot have ground ambulance fall into the NSA criteria. We are a different entity, and we are very much the stopgap for healthcare across the country. But equally important to us, or additionally important to us, is that we need a meaningful access to coverage. Many patients told us how they thought they had comprehensive coverage with their various healthcare plans, only to not only find out in the small print that nobody can read nor necessarily understand that coverage for ambulance service is either not covered or severely limited. We need it to require the process to this committee to require plans to cover ground ambulance service is an important part of consumer protection. And by that people know that they are protected, that they are not going to be surprised to find out that their insurance coverage isn't there. It's difficult for providers to know what each plan is covering, so important to have a consistent pathway for patient responsibility. We need to be transparency so that people know what is covered and that they are protected. And I appreciate, again, everyone's time and commitment to this, and we look forward to see the process continue today and into tomorrow.
Thank you. Next up, we have Katie Van Dez.
Good afternoon, committee members. I'm Katie Van Dines with Health Access California, our statewide healthcare consumer advocacy coalition. We sponsored our new California law signed earlier this month, which bans surprise medical bills for ground ambulance services and caps what the uninsured can be charged for ambulance services. We are here to share about California's new law, what we learned, and offer it as an approach for your consideration. as well as recommendations to replace the federal prudent layperson standard for emergency care with California's law that offers greater consumer protection. Under California's new law, AB 716, if a consumer is transported in an out-of-network ambulance, consumers will be prohibited from receiving a bill beyond their in-network cost-sharing amount. In this situation, the insurer or health plan will be required to pay the ambulance provider, both public and private, the remainder of the locally set ambulance rate. We chose to require payment of the locally set rate because this rate is set through an existing public process approved by elected officials responsible to their constituents, and these rates are set by cities or counties. These processes will also allow interested stakeholders to engage in that public process, including consumer advocates and health plans. Importantly, under California law, local governments cannot charge more than cost of ambulance services. If adopted nationally, there should be similar guardrails for other states and local governments to prevent increases in rates to backfill other budget needs on the backs of consumers' healthcare. To monitor the local ambulance rates, our new law requires an annual state report trending local rates by county and requires that report to be submitted to the regulators for rate review and our new Office of Healthcare Affordability. This law applies to both emergency and non-emergency ambulance transport, including interfacility transfers. We offer California's new law as an approach for your consideration and are here as a resource. We were also asked to provide recommendations on the standard for health insurance payment claims for hospital emergency care, and we recommend replacing the prudent layperson standard with the reasonable belief standard in California law with adjustments appropriate for behavioral health crises and protections for post-stabilization care. You can find more detail about all of these recommendations in our memo that we submitted to the committee. Thank you for your time and consideration and all your work. Thank you.
Thank you. Next up, we have Dawson Nguyen.
Hello, everybody. My name is Do-Sun Nguyen. I'm the Legislative Affairs Manager at the National Rural Health Association and the newest member of the Government Affairs team. Before that, I spent some time advising Congress on veterans' health and rural health policy issues. And before that, I spent some time in the courts, and I also spent 8 years as an Army National Guard combat medic. So just to go over a high-level policy positions from the National Rural Health Association, we have several issues that we'd like to raise, including we support increasing ambulance payment to adequately cover reasonable standby and fixed costs. We support considering EMS as an essential service, the same as firefighting and law enforcement. And we support collecting rural ambulance agency workforce data to better understand workforce needs. And along that line, there is the Siren Act, which is federal legislation that would provide mechanisms to support education, particularly asynchronous and distance learning for rural EMS licensure and continuing education programs. There's also legislation in Congress called the Protecting Access to Ground Ambulance Medical Services Act. This is a piece of legislation sponsored by Senator Cortez Masto from Nevada and co-sponsored by Senators Collins, Stabenow, and ranking member of the Senate Help Committee, Senator Bill Cassidy. The legislation would ensure that all communities, particularly those in rural and underserved areas, have access to quality emergency ambulance services no matter where they live, and would extend and increase Medicare payments for emergency ambulances. There's also some legislation coming down the line, which would ease the transition from military medics to civilian EMTs that you can look for to be introduced here, hopefully in the next month or so. That's all I have, so thank you very much.
Thank you. Next up, we have Wayne Jurecki.
Thank you. My name is Wayne Jurecki. I am with Bell Ambulance in Milwaukee, Wisconsin. I have been part of Bell Ambulance and involved in EMS since 1984. Much of my experience is on the reimbursement side and regulatory. My experience and that of several of my colleagues that I've discussed with in other states is that the state and local rate regulation is a very thorough process. For example, here in the Milwaukee market, when we were setting our rates with the city 911 system, the city comptroller actually did review of our financial statements to be able to make sure that the rates set would be sustaining for us as an organization, but cost effective for the residents in the city of Milwaukee. This type of process has occurred in many jurisdictions around the nation, and we just want to make sure that the committee recognizes the effort or the level of effort that has been put in by the state or local jurisdictions in setting the rates for their ambulance services. This is something that certainly can be utilized when setting what a fair payment rate structure looks like in the advice of this committee. Would like to also thank the committee members for all their time and effort over the many months, some year on this process. So thank you for your attention. Just looking to make sure that we get good, reasonable rates used for our payments going forward. Thank you.
Thank you. Next up, we have Jack Hoadley.
Thank you. This is Jack Hoadley. I'm a research professor emeritus at Georgetown University. Appreciate the opportunity earlier this year to provide information to the committee, and I appreciate all the valuable work this committee has done. I think we've all learned a lot. I just wanted to focus on what I think are the three key goals of some of the recommendations that you're going to be talking about today. One is to protect consumers from balanced bills. Another is to make sure we have fair payment to providers when they're treating patients, transporting patients out of network. And finally, containing costs for the healthcare system overall, including consumer premiums. As you think about those things, I think some of the approaches that are important from the consumers are to ban balance bills, both in emergency and non-emergency transport situations, keeping in mind some of those key findings that you've just talked about earlier this morning, but also limit cost sharing to use some kind of a standard comparable to a lesser of a fixed amount, like a $50 to $100, a percentage coinsurance, but importantly, the plans in-network cost sharing so that consumer costs are never above that in-network cost sharing level. And then as you think about setting a payment standard for providers, I think it's critical to balance the need to pay providers fairly with the need to make sure that we focus on overall costs, and critical to keep total costs in mind as we do that. Considering some ability to establish guardrails on the use of either Medicare rates to the extent that that's part of your recommendations, but also the local rates to make sure that the end result does not raise costs to the system as a whole and raise premiums. Again, thank you for all your hard work on this process, and we're always happy to provide more information if that's helpful as you go through finalizing your report. Thank you.
Thank you. Next up, we have Jamie Padford.
Yes, sorry. Yes, I'm Jamie Pafford with Pafford Medical Services in Hope, Arkansas. We're part of a 57-year-old family owned and operated ambulance service. And I've also had the pleasure of being the chairperson for the American Ambulance Association GAPB committee. And so just like so many others on this phone, so much time has been devoted to this topic, and we all find it very near and dear to our heart. So I can't thank the group enough for taking the time and your expertise and putting it to good use for our industry. The real point I want to make today is just to reiterate the importance of not just adding ground ambulance services to the current NSA. As an ambulance industry, we worked diligently for ground ambulance providers not to be included in that beginning document and later on the actual bill, because we realize that we are very different from hospitals and physicians and other healthcare providers, because at a moment's notice, as you all have heard throughout this 9-month deal, that we respond immediately when 911 is called, regardless of someone's ability to pay. And that has to be taken into consideration as we move forward. Some examples of the provisions that do not work for our consumers for ground ambulance services are the consumer protections related to the disclosures and the access to services, as well as the methodology for setting the initial payment amounts and rates. And I appreciate y'all taking all of that into consideration as you move forward. but it's so important that you make specific recommendations with specific policy modifications to ensure that we're addressing the problem of surprise billing and that it does not jeopardize our access to care, and in some cases, possibly even eliminate the ability of ambulance providers, especially in rural service areas, to respond to the needs of our local communities. So we realize that there's a cost factor. We realize people don't want rates to go up, but at the same moment, they want to make sure an ambulance is there when their family member needs it. And that's what we strive to do as our industry as well. Thank you for your hard work.
Thank you. Next up, we have Adam Fox.
Good afternoon, members of the committee. My name is Adam Fox. I'm the Deputy Director at the Colorado Consumer Health Initiative. I think we would echo some of the comments that you've already heard, and we've already provided written commentary to the advisory committee, and want to thank you for your time and work on this issue. I think we just want to reiterate that our end goal is to prohibit and ban the practice of balance billing consumers in emergency and non-emergency ground ambulance scenarios. We see through our consumer assistance program that where we help folks navigate medical billing and insurance claim issues, in particular, a significant increase in the number of balance bills resulting from interfacility ground ambulance transfers. And as you know, Colorado has at least partially addressed surprise out-of-network bills for ground ambulances in emergency scenarios. However, we still continue to see some of those as well. And it's important to ensure that consumers do not continue to receive balance bills in these cases because they are incredibly difficult to resolve. We also want to emphasize the need to limit the out-of-pocket costs for consumers, preferably to a set amount that is reasonable, though we acknowledge that operating with the in-network cost-sharing structure may be an option, but would encourage the committee to consider a set cost amount or the in-network cost-sharing, whichever is lower for the consumer. And also want to reiterate some of the commentary that you've heard, that there needs to be a balance in reimbursement for sustainability for ground ambulance services and cost containment. We would also encourage the committee to consider reasonable limitations on the level of variation allowed for reimbursement rates, as that may be important to ensure that consumers are protected in a similar way across the country. Lastly, I want to note that any sort of disclosure or notification to consumers should really focus on their rights and protections under the rules and regulations and laws that exist. As we noted in our comments, disclosure and notification in ground ambulance cases cannot be applied in a similar way to scheduled services. And in many cases, consumers do not have an option as to the ground ambulance that they are taking, whether they call 911 or are transferred between facilities or receive other services. I will leave it at that and want to thank the committee for your work. And if there is more information we can provide, we are certainly happy to do so. Thank you.
Thank you. Next up, we have Ken Godden.
There you go. You can hear me, correct?
Yes.
Thank you. Hi, my name is Kim Godden. I'm with Superior Air Ground Ambulance Service of Indiana. I also chair government relations, and I'm on the board for the Indiana EMS Association. We've been working really hard in the state of Indiana. Our association has, because in 2018, the largest healthcare provider in our state sent a letter out to all providers and said, whether you're in network or out of network, this is the rate we're paying you. And there is no negotiation. And that was in 2018. So in essence, when that occurred, that's when a larger balance bills arrived to the consumers. We're in the business, me and my colleagues in the state, we're in the business of saving lives and not billing patients, and don't want patients to be in the middle. With respect to cost containment, costs have increased significantly since 2018. That was prior to the pandemic. Since the pandemic, we've got paramedics and EMTs that are leaving the industry, working in hospitals or leaving healthcare altogether, or going to Amazon or other non-skilled jobs because those jobs can pay more. And primarily that's because when reimbursement is fixed, we as an industry can't provide those competitive wages. In our state general assembly, it tried to assist the industry and put a law in place in 2022 requiring commercial providers within the state of Indiana to negotiate reimbursement rates to make sure that all ambulance providers were in network. That legislation created 9 criteria that commercial providers would look at when they negotiate. And unfortunately, to date, we have yet to see any commercial provider use those criteria to negotiate rates. Instead, any negotiation is a take it or leave it. We're going to increase up 1 or 2% over X rate and are not taking a look at what the actual costs are within the geographic region that we operate in. So, just appreciate the committee looking at this issue. I know there's discussion about failure for there to be true negotiations, and that's really what puts patients in the middle. And we really want there to be, as Mr. Fox pointed out, there needs to be adequate reimbursement in order to maintain the system. And we realize that there needs to be cost containment to the consumer, but when the insurance company is not able to fully have those negotiations or is not willing to pay a fair reimbursement rate, that's what puts the consumer at risk. Thank you.
Thank you. Next up, we have Angela Johnson.
Good afternoon. I'm Angie Johnson. I serve as a board director. I serve as a board director for the Oklahoma Ambulance Association. First, I want to express my sincere gratitude to the committee for the time and effort invested in addressing the crucial aspects in this area. I'd like to emphasize a few key points for the committee's consideration. Ensuring prompt and clear pay requirements. I cannot stress enough the significance of ensuring prompt and transparent pay requirements. It has come to my attention that numerous plans tend to compensate patients rather than providers or prolong the reimbursement process, thereby exposing individuals to the risk of the surprise bills. It's imperative to establish measures that prevent such surprises, given that patients may not always be aware that the check received from the insurer needs to be forwarded to the provider. I would like to also underscore the importance of preventing insurers from imposing documentation demands that undermine the intended protections. While we acknowledge that the potential necessity for additional documentation is crucial to address this appropriately through an audit process, preserving the established procedures, supporting plans that prioritize fair payment to providers is essential, and these definitions play a pivotal role in establishing a consistent federal standard. I extend my appreciation for the coverage recommendations put forth by this committee. Through my experience, I've encountered numerous instances where patients believe they've had comprehensive coverage only to discover limitations or exclusions in the fine print. Mandating plans to cover ground ambulance services is crucial to consumer protection measures that aligns with the best interest of the public. I am grateful for this opportunity to provide input on these vital matters. Your dedication to this cause is commendable. Thank you.
Thank you. I'm not seeing anyone else with their hand raised. Do we have any additional public comments? Okay. We have John Giorgati. John, you should be able to speak now. Or you may be double muted, John. Okay, it looks like John has lowered his hand. So is there anyone else with public comments? Okay, we have Tony Garth. And Tony, do you have your microphone
Excuse me,
muted?
I'm sorry.
Okay.
Can you hear me now? Okay. A couple things. First of all, I'd like to make sure that public comment can be given following this meeting today, and make sure that we have who to send that public comment to. The other comment that I'd like to make is that it's my understanding that there is still some debate in regards to whether or not ground ambulance services should be incorporated into the No Surprise Act. As a consumer advocate with the Tennessee Healthcare Campaign, I fully support to make sure that ground ambulance services is included in the No Surprise Act. And No Surprise Act, I assume it'd have to be amended so that this could be incorporated. Health insurance in general is complicated. Too many things fall through the cracks, and it's very important that we don't create a separate system for ground ambulance services that's not connected to the No Surprise Act. They need to be incorporated. I know how difficult it may be and is. I've been through the health insurance reform for 30 years, trying to figure out how best to do things. And we don't need to separate entities and make this a separate thing that's not connected to the No Surprise Act. So I just want to make sure that we continue along that direction. Thank you.
Thank you. And to Tony's question, we will be sending out a survey link at the conclusion of the two-day meeting where you can provide additional public comments. Okay, do we have anyone else? Okay, Kathy Lester.
Okay, I think I'm unmuted now. Is that correct? Thank you so much. I'm Kathy Lester. I actually was one of the presenters in the May meeting, and I am the founder of Lester Health Law in Washington, D.C., and work with the American Ambulance Association. My background is in the General Counsel's Office of the Department of Health and Human Services. So I do want to thank all of the government representatives on this call and on the committee for the hard work I know you have undertaken, as well as our chair, Asbel Montez. And very much appreciate the introductions this morning to really encapsulate how different ground ambulance services are from the hospitals and the physicians that the No Surprises Act currently regulates. So I just wanted to applaud the committee for its work and offer, a statement in support of really taking the time and making sure that as we take the consumer out of the middle, that we also do not end up obliterating the ground ambulance emergency services and the interfacility transports, which enable care coordination that the country has been able to rely on for the last several decades. And so to that end, I would just say that as you look at the No Surprises Act, Congress understood that some of the one-size-fits-all approaches around brick and mortar providers do not make sense in a ground ambulance situation, and encourage you all as you think about the recommendations to make sure that we take into account the unique needs of communities and their different geographic locations, their availability of other healthcare providers in the area or lack of, and what it means to provide mobile integrated healthcare, even at the emergency and interfacility level. And so to that, I just encourage you, as you look at the recommendations, to perhaps think about the framework of the NSA, but to make sure it is tailored so that we don't endanger consumer access, patient access to ground ambulance services. Thank you again for all your time and effort, and look forward to the rest of the conversations this afternoon.
Thank you. Do we have anyone else that would like to give public comment? Okay, I'm not seeing any hands raised. Asbel, would you like to go to break or?
So we've got 15 minutes for public comment. So I'd like to extend the opportunity to the committee members. I know we'll be discussing a lot when we get to, as soon as we come back from break, starting into the recommendations, but to give the opportunity to the committee members in this last 15 minutes, if you have a 2 or 3 minute public comment that you would also like to make. So if you do, if you will raise your hand and we will call on you to give that public comment. All right. Not seeing any. Let's go to a quick 10-minute break here, Tara, and then we will come back and start right into the voting.
Okay, so we will resume at 1:10. Welcome back. Next up, we will discuss definition recommendations. And with that, I will turn it over to Asbel.
All right, welcome folks. So before we get started here, I just want to kind of go back over just a few ground rules as we get into this. But first off, I think it will be helpful to the public for us to do an introduction again of all of our committee members. So we'll call on each one of them as well, and for them to introduce themselves and who they represent on the committee, or their representation on the committee, and then we will get to a few of the ground rules, and then we will start with the recommendations. So I will start with myself. I'm Asbel Montez, and I am chair of the Ground Ambulance and Patient Billing Advisory Committee, and a designee by the secretaries as well. And so then I'll pass it to, I'm just going to go down the list. So I see first Regina, so I'll let you introduce yourself.
Good afternoon, everyone. Thank you for joining us today. I represent various segments of the Ground Ambulance Committee.
And then I'll go to Rhonda.
Hi, I'm Rhonda Holden, and I also represent various segments of the ground ambulance business. Most importantly, in Washington State, the Association of Washington Public Hospital Districts, the Washington State Hospital Association, and I do work with the hospital-based ambulance service, and I've served 9 years on our EMS and Trauma Council for Washington State.
Thanks, Rhonda. Pete Lawrence.
Hi, good morning. Pete Lawrence,
Uh-oh.
You froze there.
You froze on us. All right, I'm going to go to you, Adam Beck, next, and we'll come back.
I'm Adam Beck. I'm the representative of the health insurance provider industry.
Thank you. Ted.
Oh, Ted Van Horn, and I'm representing various segments of the ground ambulance industry as a paramedic for 20 years in multiple states across the U.S.
And Patricia.
Hi, Patricia Kelmar. I'm the representative for consumers, and I am a nonprofit advocate. I work for US PIRG, the Public Interest Research Group. We worked on the No Surprises Act. I also served on the Federal Advisory Committee on Air Ambulances a few years ago.
Thanks. Ritu.
Good morning, still for some of us. I'm Ritu Sani. I represent physicians who take care of emergency trauma, cardiac stroke. I am an emergency physician and an EMS physician who serves as a medical director for 2 suburban counties in the Portland, Oregon area. I'm also a past president of the National Association of EMS Physicians.
Suzanne.
Good afternoon and good morning to some. My name is Suzanne Prentice. I am an elected official at the state level, and I am representing those who regulate insurance at the state level. Thank you.
And I'll call on Gary.
I'm Gary Wingrove, president of the Paramedic Foundation, and uncompensated when serving on this committee. And I represent patient advocacy groups as a member of the advisory committee.
And Carol.
Good day. My name is Carol Weiser. I am a benefits tax counsel in the Office of Tax Policy at Treasury. And we work with Department of Health and Human Services and the Department of Labor on regulations regarding group health plans and individual health insurance, including no surprises. Thank you.
And Raj.
Good afternoon, still good morning for some. I am Rosalyn McLean. I work in the Center for Consumer Information and Insurance Oversight within CMS at HHS, and I am the Secretary's designee for this committee. I work with Carol and our colleagues at the Department of Labor implementing the No Surprises Act, and I also served on the Air Ambulance Patient Billing Committee a couple of years ago with Patricia and Asbel. Thank you.
And GAM.
Good afternoon, everyone. GAM Wijay Tunga. I'm director of the Office of Emergency Medical Services at National Highway Traffic Safety Administration, representing the U.S. Department of Transportation.
And then Dr. Ayobami.
Thank you so much, sir. I serve on the committee as special government employee, and I work with the state of New Jersey as program manager and alternate grant award administrator. Thank you so much for making it possible for me to participate in this August committee. Thank you.
And Lauren.
Hi, my name is Lauren Adler. I'm a health economist at the Brookings Institution in Washington, D.C. I research a sort of host of health policy, so I'm on the sort of researcher side of a coin. Brookings is a large nonprofit, nonpartisan institution and foundation, and I'm here as one of the designee as needed by the committee. One of the sort of I think the only sort of non-stakeholder slot on the a non-government slot on the participation.
And then Pete, are you back with us?
I am. I'm going to stop video here, but I'll be talking. See if I can do it. Pete Lawrence, Deputy Fire Chief, Oceanside Fire Department. And I'm representing state and local EMS officials. I've been in the fire service 43 years. I've been doing ambulance reimbursement issues at the state and federal level for 35 or so. And I sat on the negotiated rulemaking process back in the late 90s when we tried to get, I think you said 1.0 as well, of the way the system should work.
Thank you. And I believe I don't see Ali here from the Secretary of Labor's office unless I've missed. Okay. As a general rule, based upon our bylaws for the charter, because we have moved into the voting portion of this, there is no proxy allowed at this point in time. It does appear we do have quorum for voting. And so here's a little bit about the construct of where we will start. Very similar to what I talked about this morning. This will become kind of routine after a while because we have so many recommendations and options to go through. But just so you know how we're going to follow this, just so the committee will know as well as the public, I will read the recommendation, and then we will open the floor to discussion. For the committee members, of course, you can use your chat. That will be open to public record after this. But you can raise your hand for discussion, which is what I would suggest. And then I will call on you to discuss the recommendation. Once the discussion has finalized, we will close that out. And then Tara will take the vote, and she will go in alphabetical order, not like I just did to introduce y'all, but she'll go in alphabetical order, and then you will vote yes, no, or abstain. And then after the end of the voting period, if you voted no, Tara will give you the opportunity to raise your hand, and you'll be given up to 3 minutes to discuss the reason why you voted no. And then that will finalize that, and then we'll move on to the next recommendation. We will follow the recommendations in the order of consumer disclosures, as well as consumer protections and disclosures, and then into the prevention of balanced billing recommendations. At the very beginning, though, we will start with the definitions, and the general construct around the NSA framework will start the recommendation list as well. Now that the recommendations have been finalized, I know we have received several inquiries. It does, before it is publicly and put on the website, we'll have to go through 508 compliance, and then it will actually be posted at that point in time. So PRI is undergoing that work to make that happen. So I am going to start, I'll pause here and see if there's any questions from the committee on the ground rules of how we're going to conduct the voting now. All right, because we'll need a quorum if you need a break. We have allotted breaks throughout this. We will end today around 3:50. We'll close that out around 3:50 Eastern time, so we can adjourn at 4 o'clock because it is Halloween, and others, and we have a lot of committee members who have small children, as well as they even want to get up and do some trick-or-treating or what have you. And then we'll get together starting tomorrow as well. So we won't try to make this too formal. I mean, we are human, but we will kind of work through this process of allowing it. But we will kind of shut it down around 3:50, kind of do a brief closure on what to expect tomorrow, and we'll adjourn the meeting no later than 4 o'clock Eastern time as well. So you that have children or want to get to trick-or-treating, we definitely have allotted for that as well. Any questions before I start and we begin the first recommendation? All right, so Tara, let's move to the next slide. We will start down the recommendation. So the first is this. The committee recommends that while the framework of the No Surprises Act should be a base for specific ground ambulance legislation, Congress should not add ground ambulance emergency medical services into the current No Surprises Act without substantial modifications as outlined in the subsequent recommendations. The committee recommends that the following provisions that could be maintained without significant change around consumer protections, directory information, price comparison tools, continuity of care, and state and federal enforcement authority within the current provisions of the No Surprises Act. And so that is the first recommendation for the group. So I'll pause here, and if you have a question or if you want to discuss this as a committee member, please raise your hand. A minute or so. Not seeing any hands. We will move to the first round of voting. So Tara, if you will take the roll call.
Okay. Lauren Adler.
I apologize, Asbel.
Oh, sorry. Go ahead, Raj.
I'd like to, just with one revision, there seems to be the word "that" in the first line of the second sentence, I think is extra. And so I'd like to vote on a version that does not include that word.
Is that the second, where the committee recommends that?
The second "that." So the committee recommends that the following provisions could be maintained without significant And so if we could just note for the minutes that we'll be voting on that sentence, sans the second that in the second sentence.
So it will read, the committee recommends the following provisions that could be maintained. Is that what you're saying?
You could leave in that it would say the committee recommends that the following provisions could be maintained.
Removing this, I got you now. A little slow this morning. Any further discussion on that recommendation? Okay, so we will vote with that modified recommendation of eliminating the second that out of the second sentence there. All right, Tara, if you'll take the vote.
Okay, Lauren Adler,
Thank you for that, Raj. I vote yes.
Sean Baird,
Yes.
Adam Beck,
Yes.
Regina Crawford,
Yes.
Rhonda Holden,
Yes.
Patricia Kilmar,
Yes.
Ali Kawar. I think Ali's on, so Rosalind McLean,
And abstain?
Asbel Montez,
Yes.
Ayobami Agansola,
Yes.
Peter Lawrence, is Pete on?
He
Let-
disappeared again.
Let's come back to him.
Okay. Suzanne Prentice,
Yes.
Ritu Sani,
Yes.
Edward Van Horn,
Yes.
Carol Weiser,
Abstain.
Yam Wijutunga,
Abstain.
Gary Wingrove,
Yes.
okay, and we'll go back to see if Pete Lawrence is on.
Vote yes.
Okay, I think that's everyone.
Okay, hearing no votes at this point, no further discussion, and we will move on to the second recommendation. All right, so this one is around definitions. And so there will be, I think, 7 that we will vote on. And so the recommendation number 2 is that the committee recommends that Congress adopt the following definitions to align with the recommendations and findings found in the final report. And so recommendation, we'll start with recommendation 2A.
Are we going to have discussion?
Oh, sure. So we can stop with the recommendation first. And so let's go back to this recommendation. We want to have discussion on 2 before we even get to the definitions. So we'll open it for discussion. If you have something you want to say through this piece of it, if you'll raise your hand. Go ahead, Gary.
Yeah, so I don't know why I didn't catch this sometime in the past, but I wonder if it should say the committee recommends that Congress or the secretaries and the secretaries adopt the definitions, because I think it would be possible for the secretaries to do it faster than Congress could do it, and I think that's a good thing.
This is, I would say that I agree with that. That there's some things within these recommendations that would be within the power of the secretaries, so that would be a good change.
Secretaries modifying this recommendation to also insert "and the secretaries." Further discussion? Not hearing any. Okay, so we will make a recommendation first to amend this recommendation for the record that the committee recommends that Congress and the secretaries adopt the following definitions to align with the recommendations and findings found in the final report.
I think it would be or the secretaries. Congress or the secretaries.
And
So
when
that
you
it does
use
not have to be
or-
both.
Yeah, and when you use or, it means and or, so I think that's good.
I see, Regina, you raised your hand.
Yeah, I was just gonna recommend that the secretaries or their appointee or instead of and. Thank you.
So I'm hearing adopt the following definitions to align with the recommendations and findings found in the final report. Okay. Because that's not a substantive recommendation change. I'd like to ask Shaheen first, do we need to do a vote on that? I do not believe we do, but just want to confirm. Shaheen, are you on? Or maybe Raj?
Yes, Shaheen may have stepped away, but I do believe this is appropriate for us to amend it and we can vote on it here.
So the committee recommends that Congress or the secretaries adopt the following definitions to align with the recommendations and findings found in the final report. Terry, the roll on that change real quick, and then we'll move into the definitions.
Okay, so Lauren Adler. Is Lauren on?
Sorry, yes.
Okay, Sean Baird,
Yes.
Adam Beck,
Yes.
Regina Crawford,
Yes.
Rhonda Holden,
Yes.
Patricia Kilmar,
Yes.
Ali Kawar, Peter Lawrence,
Yes.
Rosalind McLean,
Yes.
Asbel Montez,
Yes.
Ayobami Agansola,
Yes.
Suzanne Prentice,
Yes.
Bree Tusani,
Yes.
Edward Van Horn,
Yes.
Carol Weiser,
Yes.
Yam Wijatunga,
Yes.
and Gary Wingrove.
Yes.
Okay. So the next recommendation is going to be actually the definitions that we'll get to. So recommendation 2A is, Rhonda, I see your hand raised.
I can wait for the discussion.
Okay, so recommendation 2A is the definition community paramedicine. So community paramedicine means the practice of providing person-centered care in a diverse range of settings that address the needs of a community. This practice may include the provision of primary health care, emergency or acute care, health promotion, disease management, clinical assessment, and needs-based interventions. Professionals who practice community paramedicine are often integrated with interdisciplinary healthcare teams that aim to improve patient outcomes through education, advocacy, and health system navigation. That is the recommendation for this definition, the adoption of this definition, and I'll open it to discussion, and Rhonda's hand is raised.
I just had a concern that maybe we need to put also known as mobile integrated healthcare, because community paramedicine is very often called mobile integrated healthcare across the United States. And I think Gary even referred to it as such in his discussion with us this morning.
Yeah, I could just add in that when it's an ambulance service doing it, it's generally called community paramedicine, and when it's a health system or nursing home or someone else doing it, it's mobile integrated healthcare. I think that's a good change.
But as a modification or edit, so community paramedicine could also be or mobile healthcare. Any other?
Mobile integrated healthcare is the way it's usually described.
Mobile integrated healthcare.
Yes.
Any further discussion on this definition? And so for the record, we'll make some modification to this definition. It doesn't take away from the technical side of that. That's more of a technical change. So we'll add or mobile integrated healthcare. Okay, with that modification, you will be voting on that to adopt this definition when we refer to it within the recommendations and final report. So Tara, if you will take the vote.
Okay, Lauren Adler,
Yes.
Sean Baird,
Yes.
Adam Beck,
Yes.
Regina Crawford,
Yes.
Rhonda Holden,
Yes.
Patricia Kilmar,
Yes.
Ali Kawar, Peter Lawrence,
Yes.
Rajala McLean,
Yes.
Asbel Montes,
Yes.
Eobami Agansola,
Yes.
Suzanne Prentice,
Yes.
Ray Tusani,
Yes.
Edward Van Horn,
Yes.
Carol Weiser,
Yes.
Gam Jatunda,
Yes.
and Gary Wingrove.
Yes.
All right, so then we'll move to 2B. So our second definition you'll be voting on is the definition of cost. Cost means those costs defined in the Medicare ground ambulance data collection system, Medicare ground ambulance data collection instrument, including labor costs, facilities costs, vehicle costs, equipment, consumable and supply costs, other costs directly related to supporting an organization's ground ambulance services that are not covered by other categories. The term also includes medical oversight costs. That is the definition before you. And so we will open it for discussion. And I see that Ritu's hand is raised.
Yep, I just wanted to reiterate or I guess since this is our first public talk, but we added in the sentence around medical oversight because many of us believe that the ground ambulance data collection system process will not fully account for the cost of medical oversight in the system. And as we talk about other provisions such as treatment in place or non-transport and paying for that and guaranteeing those payments, the importance of medical oversight is only magnified in terms of better patient outcomes and better patient safety.
Ritu, may I ask that you give us a bit of a layman's look at what medical oversight means? You know, the actual activities that might break down into.
Certainly. Medical oversight, or what is often called medical direction, is basically the kind of medical overlay of the organization. The best way to look at it is that I right now am providing health care because my agencies are out providing care to the citizens in my community. And as the medical direction or medical oversight of the entire community, there's multiple ways that I do that, both sort of prospectively by creating protocols, by creating and being involved in system education in real time, by providing online medical control or online medical oversight being readily available for my crews to speak to me if there is a unique situation, and then retrospectively by providing quality improvement in those quality improvement and quality review. But the fundamental point is that, and one of the things that's been my guiding principle throughout this entire process is as Pete has often said, this is not just about a ride. This is about this is a healthcare enterprise. And from the second a patient calls 911, healthcare is being provided in some way or manner. And it is the medical oversight of the system that really is the key component that works to ensure that the care provided is appropriate, guided by medical principle, guided by medical guidelines where applicable, and focused on patient outcomes.
Thank you. That's very helpful.
Any other discussion? Carol, I see your hand is raised.
Just as a technical point, in order for the statement regarding medical oversight costs to be abundantly clear, I'd suggest that the sentence be reworded as, in addition, the term includes medical oversight costs.
Perfect. And
so that it's clear that it's not already captured.
Perfect. And I think that'll be noted for the records when we do the final report, since it's not taken away substantively for it. I'm not sure we technically have to amend it in the piece, but we'll modify it to make sure that it's abundantly clear what this means as we work through the final report. But that's a very good point to note, Carol. Any other further discussion on what this definition means? It may wordsmith a little bit more in the final document. So you might see some technical corrections, as Carol is noting, but it won't take away from the substantive piece of what this is, what we're voting on. Okay, not seeing any further hands for discussion. Tara, I'll turn it over to you to take the vote.
Okay. Lauren Adler,
Yes.
Sean Baird,
Yes.
Adam Beck,
Yes.
Regina Crawford,
Yes.
Rhonda Holden,
Yes.
Patricia Kilmar,
Yes.
Ali Kawar, Peter Lawrence,
Yes.
Rogela McLean,
Yes.
Asbel Montez,
Yes.
Ayobami Agansola,
Yes.
Suzanne Prentice,
Yes.
Ritu Sani,
Yes.
Edward Van Horn,
Yes.
Carol Weiser,
Yes.
Gam Wajatunga,
Yes.
is Gam on?
Sorry. Yes.
Okay. Gary Wingrove,
Yes.
okay.
All right. So we will move to the next definition. And this definition and this recommendation is how we're defining emergency interfacility transport within the final recommendations and findings in the final document. Emergency interfacility transport means the transport by a ground ambulance emergency medical service provider or supplier of a patient with an emergency medical condition from one healthcare facility to another location or facility to receive services not available at the originating facility as ordered by a licensed treating healthcare provider. So any discussion on that definition? Patricia.
Yeah, thanks. So just to give a little context to anybody who is joining in the public and hasn't had the benefit of the conversations that we've had over the last couple of months, but particularly from a patient perspective, having a very clear definition of this emergency interfacility transport is really important. What we've been finding and hearing from patients throughout the country is that Oftentimes, they either get themselves to an emergency room or are brought to an emergency room that doesn't have the actual services that they need to treat their condition. So we just wanted to recognize and acknowledge that, especially in the era of greater consolidation and some communities, moving within one health system, like all their cardiac services to one hospital in a metro area, or all of their, maternity work in another hospital. So understanding that sometimes you end up in your closest hospital that doesn't actually have the care that you need. A lot of patients were finding themselves needing that second ambulance, or maybe it's their first one if they brought themselves to the emergency room, but needing an ambulance from one hospital to another. And if you're in a hospital that doesn't have the care that you need, it's still an emergency. You might as well be in your church parking lot or at home without the care that you need. So this is an attempt to clearly define the emergency nature of a situation where you're already actually in a hospital, but you're still not getting the care that you absolutely need. So that's just the context and why we felt it was important to get a definition out there.
Thank you, Patricia. Gary, I see your hands raised.
Yeah, for the benefit of the couple hundred people listening in, thank you all for being here today. I just want to also add that we had a lot of conversation about this, that it might actually be going to the higher acuity facility. When we were discussing this definition, I had my own issue of being at a level 1 trauma center, them not having a PET scan available. So I ended up going to a level 3 trauma center, but it still fits within the confines of this definition. So if you're wondering about that, we removed the higher level of care to be clear that it's necessary healthcare.
Any further discussion on this particular definition from the group? You'll raise your hand. Okay. So Tara, if you will take the vote.
Okay. Lauren Adler,
Yes.
Sean Baird,
Yes.
Adam Beck,
Yes.
Regina Crawford,
Yes, and Tara, Gary has his hand raised.
okay. Asbill, do you want to stop and go back, or?
He just hasn't turned.
Yeah, that was a mistake. I raised it for the discussion part.
Okay. So Rhonda Holden,
Yes.
Patricia Kilmar,
Yes.
Ali Kawar, Peter Lawrence,
Yes.
Rogela McLean,
Yes.
Roger, okay. Asbel Montez,
Yes.
Ayobami Agansola,
Yes.
Suzanne Prentice,
Yes.
Ritu Sani,
Yes.
Edward Van Horn,
Yes.
Carol Weiser,
Yes.
Gam Wijatunga,
Yes.
Gary Wingrove.
Yes.
Okay.
Okay, so we'll move to recommendation 2D. And this is a definition surrounding what a ground ambulance emergency medical service is according to the prudent person standard. The definition that is being recommended is ground ambulance emergency medical service means ground ambulance medical or transport services furnished to an individual for whom an immediate response was required to assess and or treat a medical or behavioral condition that a prudent layperson reasonably believed that the medical condition was an emergency medical condition and reasonably believed that the condition required ambulance services. Such services include the ground transportation of the patient to a hospital or other medically appropriate destination as defined by Congress or the secretaries. The determination as to whether an individual reasonably expected that the absence of immediate medical attention will result in serious jeopardy or harm should not be based solely upon a retrospective analysis of the level of care eventually provided to or a final discharge of the person who received emergency assistance. So that is the language of the ground ambulance emergency medical service prudent person standard to adopt. So we'll open it for discussion. If you have technical changes you'd like, we'll hear them. May not change, as long if it changes the substantive, we'll have to modify and come to a recommendation on that. But if it's technical in nature, let's discuss it, and then that can be a part of the final report. So Pete, start with you. I see your hands raised.
Yes, thank you very much. And just again, context on this. This mirrors very closely what we put in place in California in the 1980s. And the goal was that we got the patient to not think to themselves, is insurance going to deny me? So we tried to make sure that this meets all of the criteria, and I appreciate the individual from Access California that provided good input, and Patricia as well for keeping on this to get the patient to the point that they don't have to question, is this truly an emergency? So I appreciate that the language to mirror what we've been very successful, I feel, in California as getting in to support the patients. End of report.
Thanks, Pete. And Patricia, your hand's raised.
Yeah, thanks. And thanks to California for setting, a really great standard that takes into consideration a lot of different kind of educational levels, cultural differences, and, some of the nuances of what a prudent person standard is in many states. So this opens it up and gives a little bit more benefit of the doubt to the consumer to make the right decision and not be denied coverage. The other thing I would just point out, and that makes me comfortable recommending this, bit of an expansion as to, what's a reasonable standard, is looking at the information provided by NEMSIS during the public meeting that was held, I believe, in August. And what we saw there was only about 2% of 911 calls that were dispatched ended up being a no treatment, no transport. So folks generally are calling 911 when they actually need treatment, and they seem to, for the most part, be making really smart and good decisions about when they need emergency care. So I don't think we have to narrow the definition to try to make people be smarter or be more hesitant to call care. We don't see that that's a problem right now. So I think this is a great definition, and I appreciate the committee working to get it.
Thanks, Patricia. And Carol, I see your hands raised.
Just again, some technical points as to whether there has to actually be a specific prudent layperson who has a belief, or whether instead we are trying to say that a prudent layperson would reasonably believe. So that, if in some fact pattern, there actually was not a specific individual present who one would consider a prudent layperson, you would not need to be worried about whether how this would apply. So that would be, if that's a technical correction, we may not need to really resolve it now. And then just for consistency, the standard is reasonable belief in the first one sentence paragraph, but then as we go down into the second paragraph, the sentence starting with the determination uses reasonably expected rather than reasonably believed, and it might be better for those to be consistent. And again, we don't necessarily need to adopt those now, but they should be considered, I think, for the final report.
And I would agree with you on that, Carol, noted for the record as we develop and write that. Sean.
Yeah, first of all, I would agree with those last comments on the edits. I think that's in the proper spirit of what we were trying to do. And I did just want to comment, I think this definition, along with the one that we just discussed previously, are just essential to making any sort of substantive systematic change to help both consumers and keep the provider networks for access to care intact. So I think the work that's done on those two definitions is going to be incredibly meaningful. And I was very happy to hear from the person from California Consumers in public comment that they referenced and acknowledged the work in California as being successful. So I think that puts us on a good ground forward.
Okay. And I believe, and to Sean's point too, is remember this definition, this term, and the term previous that was just voted in the affirmative on the interfacility emergency transport in 2C will be referenced later in several recommendations. So it's really important to note when you see ground ambulance emergency medical service, it ties in with that interfacility definition that was voted on as well. Any further discussion on these terms? All right. If Terry, you'll take the vote.
Okay. Lauren Adler,
Yes.
John Baird,
Yes.
Adam Beck,
Yes.
Regina Crawford,
Yes.
Rhonda Holden,
Yes.
Patricia Kelmar,
Yes.
Ali Kawar, Peter Lawrence,
Yes.
Rogula McLean,
Yes.
Asbel Montez,
Yes.
Ayobami Agansola,
Yes.
Suzanne Prentice,
Yes.
Ritu Sani,
Yes.
Edward Van Horn,
Yes.
Carol Weiser,
Yes.
Yam Wijatunga,
Yes.
and Gary Wingrove.
Yes.
Okay. So let's move to the next definition. 3 more definitions to those that are listening in, and then we'll get into some more of the meat of the substance. Recommendation number 2E. So this is our 5th definition, ground ambulance provider or supplier. Ground ambulance provider or supplier is an entity that is authorized and licensed by the appropriate governmental entity to respond to a request for ground ambulance medical services. And so the committee felt this was important to define. And the reason why it's called ground ambulance provider or supplier is to stay consistent with other payer programs that, depending upon if you're a hospital-based or not, you could be referred to as a provider or supplier, as well as some other references throughout some of the recommendations and findings. And so I will stop here and leave it open for discussion. Not seeing any, we will move to vote. Tara.
Okay. Lauren Adler,
Yes.
John Baird,
Yes.
Adam Beck,
Yes.
Regina Crawford,
Yes.
Rhonda Holden,
Yes.
Patricia Kelmar,
Yes.
Ali Kawar, Peter Lawrence,
Yes.
Rogula McLean,
Yes.
Asbel Montez,
Yes.
Ayobami Agansola,
Yes.
Suzanne Prentice,
Yes.
Ritu Sani,
Yes.
Edward Van Horn,
Yes. Yes.
Carol Weiser,
Yes.
Yam Wijatunga,
Yes.
and Gary Wingrove.
Yes.
Okay. So I believe this might be our 6th definition. Next, which is 2F. is the definition of prompt payment. What does that mean? That is one of our charges. So this is how it is being defined when you see it used in a different report or in a different recommendation. So prompt payment is defined as means that a group health plan and health insurance issuer required payment under recommendation number 12 and or 14 that you will see later on, or a notice of denial of payment within 30 days of receiving a bill triggering the duty to make a minimum required payment or to issue a notice of denial of payment. It should be noted that there is another term in here that will be defined in 2G, which is bill triggering the duty to make a minimum required payment. So again, I'll say this for the group. This will begin to make sense to the public that's listening when they start seeing the recommendations. That prompt payment means that a group health plan and health insurance issuer required payment under recommendation 12 and or 14 or a notice of denial of payment within 30 days of receiving a bill triggering the duty to make a minimum required payment or to issue a notice of denial of payment. So I'll stop there and open the floor for discussion. Ted.
Asbel, we had talked because of some of the existing state balance billing laws that there was, we needed to have some comment on that, maybe something that would say unless there's a state prompt pay law that applies. Or feedback on that.
There was not a modification made to this definition. It could be made within the actual recommendation and noted when you make your vote. But as far as this definition goes, this is the definition. So if there needs to be a modification to this definition or respectively within the recommendation, where it addresses prompt payment. Any further discussion on this vote, Carol?
I'm wondering whether there are some words missing, or is this required payment? Is that a defined term, or are we saying a group health plan or health insurance issuer required to make payment or provide a notice of denial? I'm a little unsure how this is to be read.
Raj, Raj, I know you're on here and we led this piece of it. Do you have context around that? Because I cannot remember, to be honest with you.
Okay, I'm sorry, repeat the question one more time.
So, Raj, it appears to me that there may be some words missing here, or that somehow or other I'm not putting all the pieces together. Prompt payment means that a group health plan and health insurance issuer required payment under recommendation 12. So is that a defined term, or are we saying required to make payment under recommendation 12?
Yeah, I think it should be read, put a hyphen between that issuer and required, the issuer required payment under recommendation 12 and 14.
Okay.
Remind me, Asbel, recommendation 12 would be.
Yeah, when we move to recommendation 12, it is going to be around the preventing of the surprise billing.
Okay.
Around that national set rate, and then that minimum required payment.
Okay.
And then 14 is on the non-emergent. So it's addressing the preventing of the surprise bill. When we get down to it, there's a prompt payment requirement in there. And because it is not currently defined within the No Surprises Act, the committee wanted to make sure it was defined.
Right.
And so this is what they came up with.
Okay, yeah, and we can make that more clear, Carol.
Yeah, and maybe that needs to come out. We're just going to need to look at this a little more carefully to make sure that this really makes sense.
Okay.
I think that the tenor of this, and we'll let the lawyers kind of get out there and help with the technical piece to make sure it really makes sense to get to the intent of what this definition was supposed to do. And that is basically to require payment under whatever prevention of balance billing that we will do in these subsequent recommendations, that they need to issue a notice of payment within 30 days or a denial based upon the next definition we'll talk about, which is the bill triggering the duty to make a minimum required payment. So based upon that, and we will clean up this, it's going to be more technical in nature, but that's the premise of it. Any further discussion before we go to vote? All right, Tara, if you'll take the vote.
Okay, Lauren Adler,
Yes.
John Baird,
Yes.
Adam Beck,
No.
Regina Crawford,
Yes.
Rhonda Holden,
Yes.
Patricia Kelmar,
Yes.
Ali Kawar, Peter Lawrence,
Yes.
Rajula McLean,
Yes.
Asbel Montez,
Yes.
Ayobami Agonsola,
Yes.
Suzanne Prentice,
Yes.
Ritu Sani,
Yes.
Edward Van Horn,
Yes.
Carol Weiser,
Abstain.
Gam Wajatunga,
He's on mute.
Yes.
and Gary Wingrove.
Yes.
Okay. And Adam, would you like to speak to your vote?
Just that the no vote is based on the belief that a required minimum payment is not the appropriate policy solution. It's not with an issue around prompt payment itself, which is generally required also within 30 days under most state laws. So the issue is not with the definition itself or the requirement for payment within 30 days. It's more tying it to the required minimum payment, which we're addressing in separate recommendations.
Okay. Thank you for that, Adam. And so we will move to the next vote of the final definition. And this definition is a little bit more concise. There was a lot that came around as a general context around clean claim. And there was a lot of discussion that was discussed in committee around clean claim definition, or what was the objective to get to with this definition. And so the suggestion was to call it the bill payment or issue a notice of denial of payment, which will subsequently be addressed in other recommendations when you get to the prevention of a surprise bill. So the definition as recommended is bill triggering the duty to make a minimum required payment or issue a notice of denial of payment means a claim that includes at a minimum the following elements: coverage provider, insured's ID number, patient's name, patient's birth date, insured's name, patient's address, insured's policy group or FECA number, the date of current illness, injury, or pregnancy, the name of referring provider or other source, the ICD-10, the ICD indicator, dates of service, place of service, procedures, services, or supplies, including the CPT, HCPCS code, and modifiers, the diagnosis pointer, charges, days, or units, federal tax ID number, acceptance of assignment, either yes or no, that's what's in parentheses, the total charge, the signature of the physician or supplier, the service facility location, information, including NPI, the billing provider information, and the including NPI. And as I'm reading through that, I believe there's probably some technical changes and omissions that need to come out based upon discussion. Pete, I see your hands raised.
Yes, in all of the conversations that we had during the subcommittee meetings, we had removed the at a minimum. So on the second line down, that a claim that includes the following elements, we got rid of at a minimum.
You are correct. That should be stricken.
Otherwise, I'm good.
So that should be modified. Gary.
Yeah, just a question, I think, for Raj. Did we confirm that the hospital bills have all of this stuff?
We have not confirmed that yet, but we do have confirmed the plan to go through and do the same list for the facilities form.
Thank you.
So the discussion of what Gary was talking about, there are some providers that are attached to a UB, which is the hospital side of it, the institutional form. And so this definition is basically showing what the claim needs to include in order for it to trigger the duty to make a minimum required payment or issue a notice of denial of payment when we get into our recommendations on the prevention of the surprise bills. Any further discussion? So the modification to this for the record, technical, is it should have removed at a minimum. Carol?
Not actually on this, but did we skip 2G?
Oh, that's a good point. I believe that might be a typo. This recommendation is to G, not to H. So again, for the public, thanks for catching that, Carol. All right, so we will now take a vote, Tara.
Okay. Lauren Adler,
Yes.
Sean Baird,
Yes.
Adam Beck,
Yes.
Regina Crawford,
Yes.
Rhonda Holden,
Yes.
Patricia Kilmar,
Yes.
Ali Kawar, Peter Lawrence,
Yes.
Rajula McLean,
Yes.
Asbel Montez,
Yes.
Ayobami Agansola,
Yes.
Suzanne Prentice,
Yes.
Ritu Sani,
Yes.
Edward Van Horn,
Yes.
Carol Weiser,
Yes.
Gam Wajatunga,
Yes.
and Gary Wingrove.
Yes.
Okay, so we are through with definitions, and now these definitions will become relevant to many of the recommendations that you're going to start to see in front of you. And so we will move to 3. Now, of the recommendation in 3 that we will talk about, there are 2 options that we will be discussing within this recommendation. And so for the committee, I will read the recommendation number 3, but we will move to A first and then open for discussion regarding recommendation number 3A. So the way that we have put this in here through the presentation is to discuss what recommendation number 3 does, and then that there were 2 options to get to that same objective by the committee. And so we will then work through that. So we are now going to start going through the consumer protections and disclosures before we move into the prevention of surprise billing. And so the first came around the consumer protections around mandatory coverages. That's the best way to say this, or requiring coverage. So recommendation 3 is around Congress should require coverage of ground ambulance emergency medical services. So the first option to get at that recommendation is recommendation number 3A. So we'll move to recommendation number 3A, and I will walk you through what this recommendation is, and then the relevant discussion that we'll have around it. And so a plan or issuer offering group or individual health insurance must provide or cover any benefits with respect to emergency ground ambulance services, including emergency interfacility transports, then the plan or issue must cover such services. A, without the need for any prior authorization determination. B, whether the ground ambulance provider or supplier furnishing such services is participating provider or supplier with respect to such services. C, without imposing any requirements or limitations on coverage that is more restrictive than the requirements or limitations that apply to such services if they were received from a participating ground ambulance emergency medical services provider or supplier. And D, without regard to any other term or condition of such coverage. So that is recommendation 3A. In general, it is for any service where emergency medical services is requested, where a transport occurs, including emergency interfacility transports within those 4 components. And so I'll stop there and open it up for discussion on recommendation 3A. Gary Wingrove.
So I'm curious if we need to vote on the prior slide or not, because in number 2, we voted on the thing in column C of our spreadsheet before we move to column D. I'm wondering if we need to do the same thing here.
Here, Asbel, let's go back to the previous slide.
Okay.
I had a question about that too. So it was my understanding that the evolution of this recommendation was to make sure that ground ambulance emergency medical services were recognized as an essential health benefit under the Public Health Service Act and the ACA. Do I have that right?
No, there's going to be another recommendation specific to the essential health benefit under the ACA. This is actually requiring the coverage under ERISA, and which the essential health benefit does not cover that component. So this would be requiring coverage under that statutory of those 4 relevant acts that we are looking at.
Okay, that's helpful. Thank you.
And so this, to your point, Gary, through this process versus the definition, this is Congress should require the coverage of ground ambulance emergency medical services. If we didn't have 2 options to get at this, you would be right, but it's all within this. So you take it in context with this. So Congress should require coverage of ground ambulance emergency medical services. And then option A is this. So if you want to discuss anything related to this recommendation under Congress should require coverage of ground ambulance emergency medical services. Next slide, Tara. Then it's going to say this is the recommendation for that particular provision. And then when we get to 3B, it's the same recommendation, but it's a different way of getting at it. So we'll open for discussion, and Patricia.
Thank you. Because we can't explain our yeses, I'm going to take a moment to explain it here, how I'm going to be voting. So this again is getting at this issue of people getting surprise billed, and actually, this is actually getting at the fact that if you don't even have coverage for these interfacility transports, then you get the whole bill. So this is trying to start to define that really folks need and expect that their insurance coverage is going to protect them in these situations. So 3A is relating to emergency ground ambulance transportation. And then 3B is going to be one that also is similar to this, but includes the no transport in the situation where the patient ends up not going. So I agree with both, but with caveats. So I think that this is really important and people do need coverage for this because they're expecting it. And obviously, as a public health, the right public health thing is to make sure that people get ambulance services when they need them. And I also agree that the system of only paying for transportation is antiquated, and we do need to start paying for some of those no transport treatments that happen in the community. Medicine has evolved a lot, and we shouldn't unnecessarily have to drive people to an emergency room where they're then subject to so much more medical treatment and medical bills that they may not necessarily need, simply because the ambulance wants to get reimbursed for that call to the field. So it's putting me in a bind, and I don't want to vote no on either of these. I think that the ability to be able to pay for some some that end up not with transports is probably a good thing. Whether we're going to pay for all of them, I'd rather see some guardrails on the 3B. So that's just to give clarity, but I do think this is coverage that people really do need and they're expecting, and it's the right public health decision. Thanks.
Patricia is going to be able to provide more context around her 3B comment at length. That'll go into the public record as well, I'm sure. Pete?
Yeah, basically mirroring Patricia's comments, this is critical. We need to make sure that health insurance is covering EMS. Again, EMS is a system. It's not just the transport. That's why 3B, the only difference between 3A and 3B is the language that says the non-transport component. And, it's this is where we kind of get some conflict, that if both of them are approved, then essentially 3B is approved. So just, that's the whole issue here is 3A does not include the non-transport, and the patient gets the bill, and the patient is impacted financially when insurance companies do not pay for the non-transport services. When we go to the call, we assess the patient, we provide treatment, we may even give medications. The patient declines to go, or we decide that the patient can go to their own facility. There's no reimbursement, and the patient then gets stuck in the middle. That's the problem with 3A. 3B is the way to go.
And as you can tell, this is why we have a few options to the same scenario. Adam.
Yeah, just building on what Patricia noted, since we can't explain yeses, I'll be voting yes on this, but do want to emphasize the view that medical necessity determinations can and should still play a role in determining the application of coverage for these particular emergency services, including the emergency interfacility transports.
Gary.
Yeah, I feel really strongly in support of Pete's comments, but for all of the additions that are in 3B, and because I feel really strongly about 3B, I'm going to vote no for 3A.
Any other discussion before we take the vote? All right, we will, if you will take the roll.
Okay, Lauren Adler.
Yes.
Sean Baird.
Yes.
Adam Beck.
Yes.
Regina Crawford. Regina, I don't think I heard you.
Yes.
Okay. Rhonda Holden.
No.
Patricia Kilmar.
Yes.
Ali Kawar. Peter Lawrence.
No.
Rosalind McLean.
Abstain.
Asbel Montez.
Yes.
Ayobami Agansola.
Yes.
Suzanne Prentice.
Yes.
Ritu Sani,
Yes.
Edward Van Horn,
Yes.
Carol Weiser,
Abstain.
Gam Wajatunga,
Yes.
and Gary Wingrove.
No.
Okay. So I'm just going to ask those that voted no, I'll give you the opportunity to speak on your vote if you wish to. So we'll start with Rhonda Holden.
Yes, for the same reasons that Pete mentioned, I just feel like it's critical that we have coverage for when we treat and don't transport, because that's an incredible expense. And when people call 911, we have to respond. We don't have a choice. So the comment made about medical necessity, you know, being required for payment just doesn't apply when someone calls 911.
Okay, Peter Lawrence.
I'm going to make it easy. What Rhonda said and what I've said previously. We need to cover non-transport services or the patient gets impacted.
Okay, and Gary Wingrove.
Yeah, I don't believe, I feel really strongly that the cases of treat and release and other things are important and shouldn't be ignored. And that's why I'm a no on 3A, but I'll be a yes on 3B.
Did we get everybody? I think Rhonda, you have your hand raised, Rhonda.
Yeah, I just had, you know, one more comment about that, about the care that can be provided in the field, and we don't transport a patient. We could have someone who's actively coding and dies and ends up being transported by a coroner rather than by an ambulance service. And we have put an intense amount of care into trying to save someone's life. So that's another really reason why I feel so strongly that we need to vote yes on 3B and make that required coverage.
All right, so let's move to 3B. We've had a lot of discussion around that, as you can hear, and then we will take a break following this, quick 10-minute break, and then we'll begin and resume voting. So recommendation 3B is very, very similar to 3A, except it does cover such services when an ambulance has responded, but no transport has occurred. So it goes through the same elements, except it is a different option to get to 3, which is basically mandatory coverage of these type of services. So I will stop and we will open the floor for discussion. Ritu.
Thanks, Asbel. Yeah, I voted yes on 3A because since we don't count votes before, I felt that if neither 3A nor 3B passed, that would be a disservice. I think 3B is by far the better choice. And as I think the report should reflect, I think other comments that will probably say, that have already said, and that will probably say the same thing, which is that I think most of us feel very strongly that 3B is better than 3A, but we were not, the structure is not that we could pick one or the other. So it's important that we had one of the two, but 3B is, I think, far superior. The only other point I want to make about this is back to my comments around medical oversight. This is a prime example of the incredible importance of medical oversight when patients are not transported, which of course does happen frequently. There is an increased risk to both the patient and the healthcare system, and the methodology for reducing risk and ensuring proper patient outcomes is strong medical oversight. And so I just want to make sure that it is reflected the importance of medical oversight in this particular instance.
John.
Thank you. I'm going to echo Ritu's comment on 3B being really very important to get through. I know that we've heard from a lot of committee members about the need for payment for those incidences where we respond, and there are many reasons why that happens, and the patient doesn't ultimately get transported. So I was a yes vote on A, and I'll be a yes vote on B, with B being the more comprehensive option.
Thank you, Sean. Suzanne.
Thank you, Isabel. So as Sean, Baird, and Ratu have stated, well, this is about inclusivity for me. Both of these, I'm just going to piggyback or stand on the shoulders of their statements and add on here. This is about being inclusive of both. And I hear my EMS colleagues loud and clear. And if B was my only choice, then B would be my only choice, because this is something that I regularly advocate for in the state that I work within. But since we can do both, and this being important, I'm going to be inclusive and vote for both. Thank you very much.
Thanks, Suzanne. Patricia.
Thanks. Yeah. Very similar to the others. And as I mentioned before, this is the better option. I do think we missed the boat a little bit to further define kind of the types of no transport services that we might be seeking coverage for. I know that ambulances are starting to charge for all kinds of things that happen in the field, and certainly we want patients to feel like they're covered for the medically appropriate care in the field that doesn't result in transport. However, also as a consumer advocate, I always have to be thinking about the bottom line and overall costs to our healthcare system. I think we heard a lot of comments about that, delicate balance between ensuring that we're supporting our ambulance services and having 24-hour care, and that they're being paid for the work that they do in the field. But I also have to be sensitive that, we don't necessarily want to be encouraging a lot of extra billing that may or may not be warranted. So without a clearer, definition for what the types of services with no transport are that would be covered, and that ambulances would be allowed to bill for, well, I guess they could bill for anything, but that they would be covered and we would be paying for under some kind of payment program that we'll define later. I'm just being sensitive to that, but B is better. We know that there's really valuable care happening in the community and being treated in the community without having to go to an emergency room is really an important option, and we should be paying our EMS people for that care that they're doing, including the ones that end in death, unfortunately.
Thanks, Patricia. Regina.
Yes, I just want to explain, since we don't have an opportunity to explain why we vote yes as opposed to voting no. I support 3A and 3B strongly. I advocate for EMS every day across the country, and this would be my option 3B, but just in case 3A didn't get in, we wanted a backup option. So I agree. Both are good recommendations, and I strongly support 3B. I advocate for it every day. And I do think the pandemic put us on the front line where EMS is recognized for what they do other than just transporting to the hospital. So thank you.
Thanks, Regina. Adam.
Yeah, I think my question might be mostly about the phrasing, or if there's a word change that might be needed in the opening sentence. So it says a plan or issuer offering group or individual health insurance must provide or cover any benefits with respect to emergency ground ambulance services, the parenthetical, and then the plan or issuer must cover such services. And so I'm just not, I'm not following if that is, I think just grammatically, like where, if it's supposed to say, if a plan or issuer offering group or individual health insurance covers any benefits. And the reason I'm asking this is, I think my concern is over the use of the term any benefits, and wanting to vote yes on this, because I do believe that medically necessary treatment in place should be, should be reimbursed. My concern is if the term must and any benefits are in there, that's a recommendation to basically cover anything that is provided by personnel without any limitation.
So I think we'll go back to 3. If you can just bring up the general recommendation of 3, and this is option B. Congress should require coverage of ground ambulance emergency medical services. And then we get to 3B, Adam, which basically is a mandate, must. So if you go back to 3B, the recommendation on here is they must provide or cover any benefits. And so if you're a no vote, it could be an issue with this, that you're supportive of it, but not with such just broad latitude is what I'm hearing from you, correct?
Well, the main issue I was raising is I don't think there's a verb in there.
A recommendation, because that would be a substantive change to the recommendation. So you need to make that change.
Okay, it's just not entirely clear what the sentence is supposed to. I think my main issue was I think there's a verb missing. But if what this is reading is a mandate to cover without any limit any benefit that is provided or any treatment that's provided, I think that if that's what you're saying, that this is a mandate to provide any treatment without any limitation.
The limitation is the definition of emergency ground ambulance services that we already approved.
Yeah, this is the intent of the recommendation. I'll call on Gary to address Adam's standpoint.
Yeah, Adam, I was glad to hear what you said. The limitation is really in the definition that we approved on emergency ground ambulance services. And no matter how you voted on 3A, I just want to encourage my fellow committee members to vote yes on 3B because it's so important, and we're stuck in a system. Patricia, this will be important to you. We're stuck in a system where we're required to increase the cost of healthcare by transporting patients to the hospital in order to get the ambulance covered. And that's just the wrong policy way to go.
Okay, I'll go to Pete.
Yeah, again, it's this issue of we're the only section of healthcare. EMS is the only section of healthcare where we provide a service and it's not reimbursed. If we go to the doctor and the doctor evaluates us because our shoulder's hurting or we've got abdominal pain and the doctor says we can't figure out what is causing the problem, they still get paid. EMS doesn't get paid when we show up, we do the evaluation, we're assessing, we're using a $38,000 cardiac monitor. As was said, sometimes we're running a full code and some of the insurance companies are not covering it because it is a non-transport. Now, obviously Medicare has finally said they're going to cover those patients we work who are deceased. But the bottom line is the vast majority that we go to that we don't transport, it's because we've decided they don't need to go to the emergency room. And to Patricia's comment and to what Gary appropriately identified, we can increase the cost to the insurance industry and to the patients by transporting all these patients, but they're not necessary. 3B, the B is the best. The best outcome here is that no transport is covered. The patient then is not responsible for having to cover that service out of pocket 100%. And EMS is a system. If we can get all of our stuff reimbursed that we go to, the transport costs can come down. Again, we're not able to make a profit in California here, and I can't speak to other states, but I can't make a profit. I can't recover more than the cost of providing service. If we're able to level it out between those that we respond to and don't transport and those that we respond to and transport, the total cost comes down because I'm no longer having to recover the cost of the no transports as part of the cost of a transport.
Okay, Carol?
Speaking again to the technical point, I agree with Adam that the language is quite ambiguous as to exactly what is meant. I understand that recommendation 3 was these benefits must be covered. The way in which the two different phrases here at the beginning are worded is technically fairly ambiguous. I don't know whether the then the should instead be specifically the plan must cover such services, or in particular, something along those lines. But I think that there does need to be a scrub for these recommendations to make sure that they actually are conveying what it's intended.
What the intent is. And so to Carol's point, we'll note that to make sure that this language is changed to make sure that it covers the intent from a legal phrasing to say something where they must cover the emergency ground ambulance services, as well as an ambulance that has responded but no transport has occurred, to the theme of that recommendation 3B. That is the intent here. And so we will have Carol, once we do the final report, wordsmith this to ensure as we go through the technical side of it to make sure it gets to that intent.
I'm going to be retired.
Oh, Carol. I think we all want to be retired by the time this is over. Okay, any further discussion on this from my particular standpoint, as well as voting on this in the affirmative? I think that we have to remember there's two options. We can hear it through the dialogue and that's happening here amongst our committee members of the reasons why there is a nuanced option, so that there can be discussion around that. And so voting either one, remember these are recommendations that'll go in the final report with everyone's discussion points. And then remember, option 2 is our plan. Part 2 of this is Congress is going to have to act. And so they are going to have options related to that particular recommendation, which is around covering emergency ground ambulance services, including emergency interfacility transports. And so we will now go to vote on option B, which is also the inclusion of an ambulance response where transport has not occurred. And so, Tara, I will let you take the vote.
Okay. Lauren Adler.
Yeah.
Okay. Sean Baird.
Yes.
Adam Beck.
Yes.
Regina Crawford.
Yes.
Rhonda Holden.
Yes.
Patricia Kilmar.
Yes.
Holly Kawar. Peter Lawrence.
Yes.
Rajala McLean.
Abstain.
Asbel Montez.
Yes.
Ayobami Agansola.
Yes.
Suzanne Prentice.
Yes.
Ritu Sani.
Yes.
Edward Van Horn.
Yes.
Carol Weiser.
Abstain.
Gam Wijatunga.
Yes.
And Gary Wingrove.
Yes.
Okay, so we are going to take a quick break for 10 minutes, and then we'll get back and go through a few more of these before we adjourn for the day. But Rhonda, I see your hand is up if you want to make a comment.
Yes, I just hope that when we provide the narrative to Congress, that we have the discussion that we had about we all really are preferring 3B and recognize that that is the preferred option, but a lot of people voted yes for 3A just because we knew we had to get some sort of coverage there. I don't want them to think that because so many people voted for 3A that was indeed the preference of the committee.
Perfect. That will definitely be noted in the comments in that final report. Because we are not allowing, Ted, I'll ask, but because we're not allowed, unless you are a no vote, a lot of your comments have been recorded through the discussion point. That will absolutely be in the final report, and so it will be noted in the final report regarding this option. All right, Tara, we're going to take a 10-minute break. We will be back and convene here at 2:52 Eastern Time.
Welcome back. We will now resume with the recommendation discussion.
All right, so we will go for the next hour or so, and then we will suspend, do a wrap up, and then move into tomorrow on finalizing some of this up. So the next recommendation is more along the lines of consumer protections as well. You did hear some discussion around this in findings. That was addressed more towards those programs governed under the Social Security Act. But there's been a lot of discussion today. There's been a recommendation around some ambulance transports, no response just earlier that we just took for the record. But this recommendation number 4 is around the establishment of a statutory federal advisory committee. So it would be a standing committee that would advise the secretaries of Health and Human Services. And so subcommittee deliberated on this. This was discussed on what this would look like specifically for what our purview is. And so the recommendation is as follows. Congress should establish a statutory federal advisory committee to advise the secretaries of Health and Human Services, the Department of Labor, and the Department of Treasury on ground ambulance reimbursement policy to evaluate how expanding coverage and reimbursement of ground ambulance services beyond transports to hospitals, skilled nursing facilities, and critical access hospitals could improve patient outcomes, reduce overall health care costs, and support the continuum of care. Among the topics, the committee recommends that such an advisory committee consider community paramedicine, mobile integrated healthcare, advanced life support first response, treatment in place, and alternative destinations. The advisory committee could also provide guidance on how to address the rising cost of ancillary supplies, oxygen, high-cost drugs, and medical equipment in the context of pre-hospital emergency services. And so the intent of this recommendation was for a lot of information that was surrounding that may not necessarily, have an ambulance response, but emergency medical service providers do provide context around this, as well as other things that may not currently be a covered benefit, but needs further development on the ideas of coverage and then how the reimbursement actually looks, and make this basically a FACA committee that would provide these recommendations on a continuous basis to the Secretary of Health and Human Services, Department of Labor, and Department of Treasury. So I'll stop there. That's the recommendation before you for a vote, and we'll see if there is any discussion on that recommendation. I see Gam has his hand raised. Go ahead, Gam.
Yeah, thanks, Asbel. I think in subcommittee we had discussion about granting either or recommending that either Congress or the Secretary of Health and Human Services establish the advisory committee. And then my second comment would be maybe to put it on the third line where it says ground ambulance reimbursement policy, just make that period so that you don't limit the scope of the committee too much, and to make the language after that about evaluating expanding coverage, et cetera, as part of the topics that the committee may address. So I guess my first question is whether we are making the recommendation both to the Secretary of Health and to Congress.
I will ask Raj to answer that. Raj, are you on?
I am here.
I think there was a deliberation in that is because this is a committee that is responsible to the 3 secretaries. Can you opine on that?
Okay, let me back up again and Gam get you to repeat your question.
Yeah, so the first question is whether we as a committee could recommend that the Secretary of Health and Human Services establish a federal advisory committee to advise CMS on ground ambulance reimbursement policy, in addition to also recommending that Congress establish a statutory advisory committee.
I think we have the flexibility, and I'm going to defer to Shaheen here, but I do believe we have that flexibility. My question would be, to the extent that I guess it seemed that there's some overlap between those suggestions, to the extent that there's a statutory FACA committee, and then we give the Secretary of Health and Human Services the discretion. Is there kind of a reason we're kind of setting up these dual authorities?
I think it's more of a kind of a sequencing issue. My preference would be, priority one is to recommend that the Secretary establish a discretionary federal advisory committee, because again, and this is an assumption on my part, my assumption is that the Secretary has the authority to do that now. And that moving forward, the administration may want to then make that discretionary advisory committee a part of statute, so that it's part of permanent statute.
Right. I do believe we have the flexibility to shape the recommendations however we want. It's interesting though, Gavin, what you said about the kind of the order of operations. I guess I would have seen it the other way, in that we would ask, that the suggestion would be for Congress to require such a committee, and then, or either give the Secretary discretion to set up that committee, because one of the things that the federal agencies do look at is the dollars that they would have to use for that activity. So not knowing what those appropriations look like, I think we could recommend that the Secretary of Health and Human Services establish, to the extent that he has such authority, that he establishes such a committee. I think we could do that, as well as suggesting to Congress that a statutory FACA committee be set up, but probably within the final report, we would explain why we're making those dual recommendations. But I do think it's possible.
Let's go through some discussion points on this. To the second point, did we get your points covered or your questions answered, Gam? I know that was the first one.
The only other second comment would be to
put a period behind the reimbursement policy.
Right, so that you don't unnecessarily limit the scope of what the committee might
pretty much look at anything and direct on the reimbursement. I think that's a really good point there. Ritu.
The other thing that popped into my mind as I was rereading through these, with regards to supplies, drugs, et cetera, and maybe this can just be captured in the discussion, but the ongoing drug shortage and supply shortage issues. And while I know NEMSAC has talked about that, I do think that reimbursement policy can play a role in affecting those shortages.
That's good dialogue in here. I think this is just some topics relevant, can move on. But basically, to get at the objective of establishing an advisory committee, we'll talk through, hear more discussion on what GAM's recommending through the process. But to note what Ritu is saying as well as far as the discussion. Gary.
Yeah, I think GAM's got it right on the sequencing, that the Secretary could do something fairly immediately, and then Congress could make it permanent. I'm not sure how I feel about putting the period. It's simply stating what it occurs now, and I wonder if we lose something with that. So for example, if you're in northern Minnesota, 150 miles from the closest trauma center, and if you need an x-ray, there's a clinic in town that has an x-ray machine, but we can't transport to clinics and get reimbursed. They can only be an intermediate stop when you actually go to the hospital. So you tag on a lot of patient cost and healthcare system cost because we can't simply take them to the clinic. So I kind of feel like because it's existing policy, the period, I wouldn't move the period, but I'm not completely wedded to that. And then I just also wanted to say, sort of on, but also off topic, when we had the rural cost plus reimbursement discussion, it went from recommendation to finding to recommendation to back to finding. It never made the switch over to the finding. So I just want to make sure when KPMG does their thing that that particular piece is in the findings.
Yeah, it'll be in the findings and the findings documentation that'll be actually posted in the presentation too, Gary. To the point.
Thank you.
Thanks.
That's it for me.
Yeah, Sean.
Yeah, I'm a little concerned about making many changes to this particular recommendation. I think that the items that are specifically included in here are items that dropped out of subcommittee discussions for very particular reasons as we worked through the various topics over the last 5 months, and we realized that this particular FACA committee wouldn't have either the bandwidth or the statutory authority or whatever to address a very specific need. So I'm not going to be favorable to adding the period just after reimbursement policy, because that in and of itself all of a sudden makes it relevant to all kinds of things that we have other processes and recommendations around and ways to go that I'm not necessarily thinking establishing another committee with wide open range is appropriate at this time.
Okay. Carol.
Again, more of a technical point in that until Congress has, while I'm certainly for providing flexibility to the departments and HHS in terms of setting up a committee, until Congress has acted on some of the aspects of other recommendations, I don't know that an HHS committee, an HHS sponsored or established committee would in fact be able to accomplish much. I don't question the authority of the Secretary of HHS to set up a committee to advise, but without the other recommendations, I question whether the committee would be able to accomplish anything.
And Ted.
And I think a little bit to the point of there is so much information that's constantly changing in EMS, and what was falling out of the committees and the subcommittee meetings over the last few months, and specifically when you talk about among the topics, another reason why not to necessarily have the period, because it is about advanced life support, first response, fire first response, the treatment in place, making sure we're communicating those things consistently as the changes happen, and to have an advisory group standing, I think is a good thing. And I don't recommend we change this as it currently sits.
Any more comment on this? I'm hearing generally from any of the committee members. GAM. Go ahead, GAM.
Yeah, I'll withdraw my comment about the period. I think since we have and support the continuum of care, that would keep that committee appropriately broad in its scope. What I would recommend adding would be a specific sentence advising the secretary to use the secretary's discretion to create a committee. So here's some recommendation for maybe a lead-in sentence. Using existing authority and appropriations, the Secretary of Health and Human Services should establish a federal advisory committee to advise CMS on ground ambulance reimbursement policy, and then lead right into Congress to establish a statutory federal advisory committee.
So I have a question maybe for Shaheen or Raj based upon that, because does our authority give us the ability to advise the secretary on payment authority that is outside the scope of the Public Health Services Act, ERISA or whatever? Because I think CMS is governed under, if we're looking at CMS payment authority again, that falls under the Social Security Act. Is that correct? Or am I off somewhere? So I know we put that in the findings to recommend on that piece, Cam, but if we're talking specifically around ERISA, PHSA, or whatever, you're going to have all three secretaries involved, not just Health and Human Services.
Right. So I would think, Asbel, anything like that would, to the extent that they are not within our existing authorities, would be a recommendation pointed at Congress.
So Cam, does that change anything on what you're recommending? Because that's substantive. So we'll have to make another, we can maybe vote on this and then vote on another on that piece as well.
Yeah, I agree as well.
Okay. Any further discussion? Okay, let's take a. Go ahead.
Sorry, can you just clarify that there will be a separate recommendation? Is that what we're thinking about related to?
No, there won't be, because it doesn't fall into the purview. It's going to be a key finding, Patricia. It's in the key finding, but because our purview does not, we can't direct something to see because it falls under the Social Security Act.
So we're just voting on what we see here on the screen today.
That is correct. Any further discussion on this vote? All right, Tara, if you will take the vote.
Okay. Lauren Adler,
Yes.
Sean Baird,
Yes.
Adam Beck,
Abstain.
Regina Crawford,
Yes.
Rhonda Holden,
Yes.
Patricia Kilmar,
Yes.
Holly Kawar, Peter Lawrence,
Yes.
Rosalyn McLean,
Abstain.
Asbel Montez,
Yes.
Ayobami Agonsola,
Yes.
Suzanne Prentice,
Yes.
Ritu Sani,
Yes.
Edward Van Horn,
Yes.
Carol Weiser,
Abstain.
Yam Wijatunga,
Yes.
and Gary Wingrove.
I'm yes, but Asbel, the wording on here is different than what we have on our spreadsheet. What we have on our spreadsheet is basically what Gam said. So I wonder if we're voting on the right one.
It's what's on my spreadsheet. And so I'm going to defer to Tara to confirm that the recommendations that are updated in that version, what version are you looking at, Gary?
Boy, that's a good question. I thought it was the one I grabbed this morning.
It should be the most recent one on Vox.com.
All right. I'm not sure I have, let me check.
Okay, so we'll move from the thanks. If you'll just let us know in chat or something like that, Gary. Okay, that has passed. There was no no's on that. And so we'll move into the next recommendation, number 5. Okay, so recommendation number 5, and this goes to a question that Raj asked earlier about the emergency health benefit requirement, which technically is under the ACA, a little different than what you voted on in recommendation 3. This is basically a recommendation that says ground ambulance emergency medical services should be incorporated in the definition of the emergency services under the essential health benefit requirement. So before we move to discussion on that point, I'm going to ask and put Raj on the spot to just discuss that essential health benefit so you realize and understand the context of what you're voting on. There may be some questions about how does that relate or not. So.
Right. So under the Affordable Care Act, there are a list of what Congress referred to as essential health benefits that had to be covered by all comprehensive health insurance plans. And what that means is that once it is an essential health benefit, there can be no lifetime annual limits, and they must be covered. So in terms of ground ambulance emergency medical services, already within the scope of the essential health benefits are emergency services. However, Congress did not further define what emergency services actually means. So one of the things that I think the committee discussed is that because right now we have different plans that provide different levels of coverage for ground ambulance emergency medical services, is that the industry, the public, consumers would benefit by clarity under federal law that ground ambulance emergency medical services are within the definition of emergency services under the essential health benefits rules. So that's where we are here. And I think we have, as the federal government, we've received this question before, and we have not responded with a direct rulemaking or a direct clarification. So I think the point of this recommendation was to provide clarity in that area and make clear that ground ambulance emergency medical services are essential health benefits that must be covered under every ACA compliant plan. Asbel?
Perfect, thanks. So any further questions? Gary, I see your hand is raised.
I didn't unraise it, but I just did put something in chat for you.
Okay. Any discussion around the essential health benefits? All right, not hearing that. Tara, if you'll take the vote.
Okay, Lauren Adler,
Yes.
Sean Baird,
Yes.
Adam Beck,
Yes.
Regina Crawford,
Yes.
Rhonda Holden,
Yes.
Patricia Kelmar,
Yes.
Ali Kawar, Peter Lawrence,
Yes.
Rodula McLean,
Abstain.
Asbel Montez,
Yes.
Ayobami Agonsola,
Yes.
Suzanne Prentice,
Yes.
Ritu Sani,
Yes.
Edward Van Horn,
Yes.
Carol Weiser,
Abstain.
Gam Wijatunga,
Yes.
and Gary Wingrove.
Yes.
All right. So our next consumer protection is going to be recommendation number 6. And this recommendation is relative to billing a patient for a service while you're seeking insurance information. And so the general context around it, I'll give from the context perspective, I'll ask Patricia and or Lauren, who really worked extensively on a subcommittee around this. And so I'll give them the opportunity to kind of give more context for the record relative to this before we do the vote, and then open it up for comment. But Congress should place a limitation on billing patients for ground ambulance emergency and non-emergency medical services before seeking insurance information. 1, a ground ambulance organization may not bill a patient until after it has been submitted to the patient's insurance company and a determination of payment has been made, unless the ground ambulance emergency or non-emergency medical services provider or supplier first make a reasonable, there's a technical, make a reasonable attempt to obtain the patient's insurance information, but was unable to do so within 3 to 7 days. Is the recommendation. So I'll put Patricia on the spot and see if she wants to give some context around that as well.
Absolutely, happy to. Thank you. Yes, so as we all know, medical bills are really confusing, and between explanation of benefits and bills that we get before they got submitted to insurance, it's really hard for consumers to always know whether they actually owe the bill that's in front of them. So this is an attempt to get a little bit better clarity and make sure that patients aren't receiving a bill too soon, and making sure that the insurance company and the ambulance providers are doing their best to share the insurance information back and forth so that if and when a bill is sent out, it's reflective more accurately of what insurance has paid, whether the claim was submitted, and that information. So that's the point behind this. I do have a clarifying question though for folks, because we only just put in this 3 to 7 days thing. And I've been thinking about it in terms of our earlier discussion around prompt payment. So in the prompt payment situation, we're thinking that there might be that we're giving the insurers 30 days to decide whether they deny the claim or are going to pay it. But this is a much quicker time frame. So I'm wondering, is this actually solving the problem that a patient will get a bill too soon when the payment determination has not yet been made? Have we closed that loophole with this wording?
So I see, I'm trying to look and see. I see Pete Lawrence, your hand is raised for discussion now.
Yeah, Patricia, this has nothing to do with the insurance company making the determination. This is that we won't send a bill to the patient until we send it to the insurance company and the determination of payment's been made. So there's that 30-day time frame. The only time that this comes into play is if we've been unable to get insurance information either from the hospital, which for those people listening, the subcommittee, we've got future recommendations coming that require hospitals to provide the information to ambulance services. If we can't get that information, then we will send a notice to the patient after the 3 to 7 day time frame that we've been trying to get it, that says, and I believe the future stuff is going to say, this isn't a bill, we're looking for your insurance information. So kind of two separate things here, but the patient will, we're still going to give the insurance company the 30 days to figure it out before we send a bill to the patient, because they have to come back with a ruling. But this is about how long do we wait before we send information to them, or a letter saying, hey, could you give us your insurance info?
Thanks for the clarification.
And Rhonda, your hand is raised.
Yeah, thank you. So my question is, what if the patient doesn't have insurance at all? What type of a time frame do we have to wait before we can send a bill to a patient if it's known that they don't have insurance?
So right now, the way this is on the book is you basically have to attempt to get it within 3 to 7 days. And so you have to make a reasonable attempt. And so after 7 days, technically, if Congress was to adopt this, put this into some type of the congressional statute around this, then theoretically you wouldn't be able to bill them until after day 7. Good question. Ayobami.
Yes, thank you. My only reservation about this is our use of the phrase reasonable attempt. To me, the phrase reasonable attempt seems vague and not deterministic. So should we use the word reasonable attempt? I think I expressed that earlier before now. Thank you.
So I'm thinking, I believe if I can repeat back what I believe that you are attempting to do here is a reasonable attempt seems vague, and that maybe we need to be a bit more specific, or maybe remove that and just say obtained, remove out a reasonable attempt. Is that what I'm hearing you say?
Yes, the concept of an attempt being reasonable is vague, and we should not introduce any ambiguity.
Reasonable language, I believe, is being used throughout some of our documents. It's used throughout other payment policy mechanisms as well, from a reasonable perspective. But in this instance, reasonable may not be the appropriate word. Ted, I see your hand raised.
Yeah, I think it's because there's multiple different ways in which providers attempt to communicate with the patients after we've completed a transport from either information from public health information exchanges, facilities information, potentially getting phone numbers and electronically communicating with them, emails. So there's a lot of different ways that happens. And it's really getting away from, I think, as even Patricia talked about, like just sending a bill or by mail to a patient, because that isn't necessarily the most effective way. It's working with the patients to communicate, to get all that appropriate information on what their insurance information is, so that we can appropriately then notice the insurance company. So that's why the 3 to 7 days allows for that process to happen, but it's from multiple different ways in which those occur.
And I know from my discussion point, and I'm seeing if you have any further discussion, but I do want to be on the record here, that based upon my background and understanding some of the nuances of working with ambulance organizations, that a typical key performance indicator on what we would call days to bill is typically between 5 to 7 days. I mean, that's best practices. Some do better than that. I have concerns with this limitation specifically because I believe it's administratively burdensome without some additional recommendations passing that would require the interchange of information depending upon the facility that you might be, the destination facility, and that incorporation of it, especially around the emergency side of things. Most times, depending upon that acute medical condition of the patient, they do not have the ability to tell you what type of insurance they have. And so you're really relying on other sources and disparate sources to find that. There are technology solutions that many incorporate or within billing departments to try to find that information on behalf of the patient. But to put a finite date, a number around that could be a little more administratively burdensome or create a delay in the process that really maybe not be consumer friendly or consumer protection outside of getting a bill. And so I do think that this recommendation does work in tandem if other recommendations are also adopted. And there is a requirement for this sharing of information in an expeditious manner. Other than that, I think the number should be very relatively, or we should further define what reasonable is, to Dr. Ayobami's point as well. And Regina, I see your hand raised.
Yes, Asbel. As we discussed this earlier in our subcommittee meeting, that was my concern. There's already a process in place, and we were just trying to find some kind of reasonable attempt for the collection. That's why I threw out the 3 to 7 days. I'm open to other suggestions, but at that point, we were trying to say if this would go along with the other things in place, this would be a reasonable time frame. But it would be burdensome to add anything. Billing companies already do this, and they go through the process of a health exchange to get data. They work with insurance companies to get data. Their process is already existing and in place. But there's health exchange processes we go through, and there's several databases that are cross-referenced with that face sheet. So I'm not real sure what the other solution would be to this concern.
Any further discussion on this very particular recommendation before we go to vote on it? It is a consumer protection. Anything further? Okay, Tara, if you will take the vote.
Okay, Lauren Adler,
Yes.
John Baird,
Yes.
Adam Beck,
Yes.
Regina Crawford,
Abstaining.
Rhonda Holden,
Yes.
Patricia Kilmar,
Yes.
Ali Kawar, Peter Lawrence,
Yes.
Rajala McLean,
Abstain?
Asbel Montez,
Yes.
Ayobami Agonsola,
Yes.
Suzanne Prentice,
Yes.
Ritu Sani,
Yes.
Edward Van Horn,
Yes.
Carol Weiser,
Abstain.
Gam Wijatunga,
Yes.
and Gary Wingrove.
Yes.
All right. So let's move to recommendation number 7. This will probably be our last recommend, depending on how long it goes. Oh, this will be an easy recommendation for the most part, I believe, before we move into the next one as well. So recommendation number 7 was another very consumer protection. Some of this is currently covered within the No Surprises Act. We wanted to call this out to make sure that this was given, for the lack of a better word, some airtime to make sure that it's really, really clear that the consumers have the ability, and this should be something when we get through a few more recommendations down the road around certain elements. And so this one would direct Congress, or Congress should direct patients with concerns, disputes, and questions about ground ambulance, emergency, and non-emergency medical services billing to the No Surprises Help Desk. The No Surprises Help Desk triages patient calls and connects them with the right resources back to their insurers, providers, or to the local regulators or federal regulators at CMS or DOL. This was something that was dialogued with the subcommittee on consumer protections and disclosures that the committee felt to bring forward as a recommendation. So again, I'll defer to Lauren and Patricia's committee. This is where it came out. We dialogued as an entire subcommittee, and this recommendation is on the books for that. So Patricia, if you'll just give context for the public around this, and then we'll move to discussion.
Sure. Yeah. So, you know, one of the most difficult things when we pass new consumer protections is to help people know and understand their new rights. And when the No Surprises Act was passed, there was a lot of effort to make sure, because it's so complicated, billing is complex, that there would be a one-stop shop for folks to be able to call an 800 number or to write to one email explaining their situation. Understanding under the No Surprises Act that states also had some state laws and that there was going to be different levels of state enforcement or federal enforcement, it would be impossible for a consumer to understand like where to go and how to get their questions answered. So there was created the No Surprises Help Desk, and their job really is to kind of understand and figure out what the problem is that the consumer is calling about, and then connect them to the right source of a solution. And so there you can see in the slide, you know, some of the different places that they will send patients. But sometimes they handle the issue themselves if it's under their purview, under CMS's purview. So just thinking that people will think about medical billing all as one and won't necessarily think about whatever new protections they have around ambulance billing. I just thought it would be a good recommendation if we just sent people to the exact same place that we're already trying to tell people about and send them to.
All right, so we will open up to discussion. Patricia, thank you for that context for the public as well. Any discussion on this recommendation? Not seeing any hands raised. We will ask Tara to do the vote.
Okay. Lauren Adler,
Yes.
Sean Baird,
Yes.
Adam Beck,
Yes.
Regina Crawford,
Yes.
Rhonda Holden,
Yes.
Patricia Kelmar,
Yes.
Ali Kawar, Peter Lawrence,
Yes.
Rodula McLean,
Abstain.
Asbel Montez,
Yes.
Ayobami Agonsola,
Yes.
Suzanne Prentice,
Yes.
Ritu Sani,
Yes.
Edward Van Horn,
Yes.
Carol Weiser,
Abstain.
Gam Wijutunga,
Yes.
and Gary Wingrove.
Yes.
Okay. So thank you, everyone. So our next is going to be the consumer protection number 8. And this one has 3 options around it. And there will be 2 of these consumer protections that we will talk about. And this is really around the maximum cost sharing amount. One is going to be around the ground ambulance emergency medical services. And then we will vote on one later on down the road around non-emergency ground ambulance emergency medical services. And so this was a lot of discussion that happened. This happened in the subcommittee right after the first public comment period or the first public meeting when we had our subcommittees chaired by Lauren and Patricia that really talked a lot about the maximum cost sharing. And you've heard about that in some of the key findings and background information that we shared earlier today. So this recommendation, number 8, is establish a maximum cost sharing amount for the participant, beneficiary, or enrollee for ground ambulance emergency medical services. Any cost sharing payments made by the participant, beneficiary, enrollee with respect to ground ambulance emergency medical services must be counted toward any in-network deductible and out-of-pocket maximum in the same manner if the services were provided by an in-network provider or supplier. Now, there were 3 options to get at this recommendation, different ways to do it, and we will take a recommendation on all 3 options, but I will stop here on this recommendation and open for discussion to see if there's any questions about the recommendation, and then we will vote on the different options to get to the same way. It's just different solutions to the same one, to the same recommendation. So I'll open the floor for discussion on the recommendation. Gary Wingrove.
Yeah, I just have a general comment. I sort of think like we should give direction. Options are okay, but I'm not going to vote yes for all of these. And I think there's a specific one that's a standout. So that's just my general comment.
Okay. Any other discussion before we get to the option? Patricia.
Just to give a little context for folks on the phone who maybe weren't involved in a lot of these discussions. The second paragraph there, I just wanted to point out is mirroring what we see in the No Surprises Act, just recognizing that oftentimes if it's an out-of-network payment that you're making, that doesn't count towards your deductible or your out-of-pocket maximum. But under the No Surprises Act, people were getting those protections in the cases where balance billing was happening frequently. So we're trying to mirror that same kind of protection. If you are having to pay, something, a cost share or something to a ambulance provider that is not in your network, it still would be recognized as an amount that goes towards your maximum out of pocket or your deductible.
Great point. Any more discussion on the recommendation before we move into the first option? Thanks for that. Okay, so let's move. There are 3 options that you can vote on to recommend to Congress and the secretaries and others that will be reading this report on how to get to this consumer protection. So we'll start with option A. And this option states the patient's cost sharing requirement is 10% of the rate established under a recommendation that we will talk through on the preventing of balance billing, which is number 12, subject to any out-of-pocket limits with a fixed dollar maximum. And so this recommendation of an out-of-pocket is going to refer to 10% of a rate methodology that the committee will vote on in a subsequent recommendation when we get to talking about rates. Patricia, are your hands up still up, or was that from something else? Okay, I'll go to Lauren.
Hi, thank you. I just wanted to give some context around at least why I'm going to vote yes on this and the next recommendation here. Right, I think folks might notice that this is somewhat different than the sort of standard cost sharing protection under the No Surprises Act. So right, in the No Surprises Act and in basically every state law, including those addressing ground ambulances, it just basically says cost sharing can be no higher than it would be for an in-network service, so an in-network ground ambulance emergency service. I think that is inadequate in the context of ground ambulances, where really there is, in the research I've seen, 85% of transports are out of network. And if you just say cost sharing has to be no higher than it is in network, you are leaving open a scenario where the insurer's incentive, especially when there's a generous payment requirement there, is to simply say, fine, there's no balance billing anymore, but we're going to change our in-network cost sharing amounts such that it's much higher. And you really don't necessarily, I think you don't solve the problem of this sort of balance bill. All you've done is now, sure, there's no balance bill, but there is higher cost sharing than there was before. And I think that's a big weakness in the sort of California and Texas laws that we've seen recently, that it might not actually reduce out-of-pocket costs. So these sort of protections where it says, sure, no higher than 10% or no higher than a fixed dollar number really get at that, what I view as a key issue here.
Any further discussion? Great points, Lauren. Any further discussion on this option A that you'll be voting on? Thanks for that context. All right, Tara, if you will take the vote.
Okay. Lauren Adler,
Yes.
John Baird,
Yes.
Adam Beck,
No.
Regina Crawford,
Yes.
Rhonda Holden,
Yes.
Patricia Kilmar,
No.
Ali Kawar, Peter Lawrence,
Yes.
Rogela McLean,
Abstain.
Asbel Montez,
Yes.
Ayobami Agonsola,
No.
Suzanne Prentice,
Yes.
Ritu Sani,
Yes.
Edward Van Horn,
Yes.
Carol Weiser,
Abstain.
Gam Wijatunga,
Yes.
and Gary Wingrove.
No.
Okay, so we will now give an opportunity for those that voted no to speak. So we'll start with Adam Beck.
No comments on that particular vote.
Okay. Patricia?
Yeah, I'm voting no on this. Not that I don't believe that there should be some type of cap, but I think option B is better. I've talked to patients who have bills in $8,000, $7,000, $10,000 ranges. 10% of that would be really hard to meet and would be a real deterrent for people to call an ambulance. The other thing I would say is I would really like folks to have a very clear idea in their head of how much this ambulance ride is going to cost them before they call 911. And I think having 10% of a rate that's, depending on how the recommendations go later, could be variable by the community that you happen to have an accident in, is just a really not a great way to set a rate or have people understand what their coverage is. So I'm going to be voting for option B.
Okay, Dr. Ayo?
Yes, my reason for voting no is that 10% as a flat rate, I'm somewhat not comfortable with a flat rate. And that is my major concern about that. I don't want to subject patients to a flat billing, a flat portion rate at 10%. I just don't like the idea of being a flat rate, and that is it. Thank you.
Okay, and Gary.
Yeah, I mostly agree with Patricia. And I think there are some areas where there's recommendations we're going to hit where there's one standout option and the others aren't very good. And I just think it's not good to confuse people by saying, here, pick one of these three choices when there's a standout option and option B is that standout option. Otherwise, we're just saying, we couldn't come to consensus on what it actually was.
All right. So I think we've closed that out. Everybody's been given the opportunity that said no, with varying, differing opinions on that. So let's move to option B. So option B, to the same definition, gives another solution to the same recommendation. And this one is the patient cost sharing requirement may be the lesser of $100 adjusted by the CPIU annually, or 10% of the rate established under recommendation number 12, which we will be talking through the prevention of balanced billing, basically the prohibition, regardless of whether the health plan includes a deductible. So this is basically establishing a fixed number as well. So I will open this for discussion. Ritu.
Yeah, just like similar to 3, to recommendation 3, I voted yes on A because that would be better than nothing. But I would agree with Patty's statement that this is a better solution, and we'll be voting yes on this.
And Lauren.
Thank you. I have 2 points. One is a technical one, which I don't know how to deal with at this point, but I feel like the language really should be patient cost sharing requirement may be no higher than the lesser of, because otherwise it's just a may statement and doesn't read like it actually has the force of law. I know what's intended, and I know that's intended to be the actual maximum, but from technical purposes, I don't know that may need to be amended in the language of the recommendation. And then second, just sort of on the broad point, again, I think this is my preferred solution as well. I take Patricia and Ritu's point. I did want to sort of vote for the other one as well, in part because I do view this level of protection as really only viable. And I think one of the advantages of choosing a sort of minimum payment standard or some sort of payment rate requirement that does have some limit in dollar terms or in a percentage of Medicare, because it is really only when there is that sort of guardrail on a payment that you really can be this protective of consumers, which I do think is the core goal of this committee. And I know this sort of goes above and beyond what we do for other even very important medical care. But I think to points that Patricia has made, I do think emergency medical services do hold sort of a special regard in terms of an expectation of limited or zero cost sharing. There are many localities who do zero out cost sharing for these services already. So there are already some areas making that choice, and often it is sort of basically if they have enough financial means to make that decision. So I do think that makes sense as a federal policy to sort of do this, and that it goes right. This is a strong protection because this applies even before your deductible.
And I think that point is well made by Lauren. The intent here would be to make sure that, and so in the final report, as we put more detail around that, the spirit of the recommendation may be modified slightly, won't take away from the substantive part of what you're going to be voting on as well. So this is that. Any more comment here? I know there's several options, several strong opinions about having one, but the committee landed on different solutions to this. I'm on the record as well. I actually agree with the point that Patricia has made, as well as Lauren and others here have made too, that this is the best protection for a consumer, is to have some finite number up to capping that allows them to know if I access EMS or emergency services through a ground ambulance, whether it's that or through the emergency in a facility, is a maximum number I'm going to have to pay. And Gary, I see your hand is raised.
Yeah, this is another one where the language on the slide is different than the spreadsheet. I think the slide actually has it correct. It's recommendation 12. The spreadsheet says recommendation 5. But before we vote tomorrow, could somebody just make sure that the language is consistent? Because I'm using this spreadsheet a lot.
I'm not sure, Gary. We'll talk through later after that, because you seem to be the only one having that issue. So we'll try to figure that out, Gary. Let's any other discussion before we take a vote on this, Pete?
You know, I just was going to comment to Gary. Remember the conversation yesterday, and they've changed the numbering. So what is now recommendation 12 used to be recommendation 5. So 12A, 12B was old 5A, 5B. So if you're using the old spreadsheet, then that is the reason why you're seeing 5.
Oh, okay, that's probably what's happening then.
Any further discussion before we go to vote on option B? All right, Tara, if you'll take us through the vote.
Okay, Lauren Adler,
Yes.
John Baird,
Yes.
Adam Beck,
No.
Regina Crawford, Regina, are you on mute?
I did say yes. I'm sorry. Then I went on mute.
Okay, Rhonda Holden,
Yes.
Patricia Kilmar,
Yes.
Ali Kawar, Peter Lawrence,
Yes.
Rodula McLean,
Abstain.
Asbel Montez,
Yes.
Ayobami Agansola,
Yes.
Suzanne Prentice,
Yes.
Ritu Sani,
Yes.
Edward Van Horn,
Yes.
Carol Weiser,
Abstain.
Cam Wijatunga,
Yes.
and Gary Wingrove.
Yes.
Okay, and Adam, we want to give you an opportunity if you want to speak to your vote.
Just one of the other options is my preference here. No other comments on the first two.
Okay.
Okay, so we will move to option C, and this will be our last vote of the day before we adjourn. So recommendation number C, or option number C of recommendation number 8 regarding consumer protections on maximum out-of-pockets. The patient cost sharing requirement for ground ambulance emergency medical services may be no higher than the amount that would apply if such services were provided by a participating ground ambulance emergency medical services provider or supplier. This is very similar to what is currently within the No Surprises Act. that Lauren was alluding to earlier for just a point of reference. So we'll open this up for discussion. I think everybody's getting excited about adjourning the recommendations. Okay, hearing none or seeing none, hands raised.
Sorry.
Go ahead, Adam.
Yeah, just one comment, and I'll be voting yes on this. I think aligning this with the cost sharing approach that applies to other services under the No Surprises Act has worked and makes sense here. Operationally, I think one of the things that's going to be challenging is, since we're not recommending an approach like the No Surprises Act has, where cost sharing is really based on a recognized amount or the qualifying payment amount, and then what the in-network benefits would be based on that particular recognized amount or QPA. That's really what makes this work in the No Surprises Act. We're it seems like going to be recommending this required minimum payment, which we've for a while kind of talked about in the vein of a QPA, but it is still different. So just I think this could work, but there are some dots that in the approach that it looks like we're going to be recommending, I don't know that they're fully going to connect. So I think it would be on Congress to connect some of those dots so that there's a measure of what the in-network amount would be, so that you can calculate the enrollees cost sharing. But otherwise, I think directionally this is my preferred option of number 8.
Okay, Pete, I see your hand is raised.
Yeah, just I think back to Lauren or Patricia made the comment that under this proposal, basically, if an insurance provider says that, okay, the participating ground ambulances, your cost share is going to be $400. Most people don't look at their insurance plan before they sign up. They don't look at the individual aspects of it, and they're never going to call an ambulance. What this does, though, is this establishes that the number is going to be huge. And I think, to Patricia and Lauren's comments, that we need to have something that is limiting, so that the individuals are not saying, I wonder what it's going to cost me to call the ambulance. So I'm going to be voting no on C.
Any other discussion? If you're going to be voting no, you'll have the point to make a discussion piece. But if you are any more discussion relative to this option? Okay, Tara, if you will take the vote.
Okay. Lauren Adler,
No.
John Baird,
No.
Adam Beck,
Yes.
Regina Crawford,
No.
Rhonda Holden,
No.
Patricia Kilmar,
No.
Ali Kawar, Peter Lawrence,
No.
Rajala McLean,
Abstain.
Asbel Montez,
No.
Ayobami Agansola,
No.
Suzanne Prentice,
No.
Ritu Sani,
No.
Edward Van Horn,
No.
Carol Weiser,
Abstain.
Yam Tunja,
No.
and Gary Wingrove.
No.
Okay, and now I will open it up for those that voted no, if you would like to speak to your vote. So we will start with Lauren.
Sure. I mean, I think for the same reasons that Patricia and some others have stated, I think, while I think this is better than nothing, I think it is voting no here because I want to sort of show my support for having more of a fixed metric, with the acknowledgement that I do understand that it is difficult to go away from something like this if it's simply left up to the sort of local governments to set rates like in recent state laws.
Okay, Sean?
Yes, some of my thoughts have already been captured on looking for greater certainty in what that amount would be for a consumer. But something that hasn't really been emphasized is the lack of data around actual in-network rates now, because there are so few in-network providers in the ambulance world with insurers, that I see this as being problematic in the sense that there's no real data set to work off of that's meaningful when no negotiations took place to, in a broad scheme like other health providers, to be a network.
Okay, Regina?
I concur with the comments that I've made previously. You don't know what that bill is going to look like, and I think it just could be really astronomical. And my concern is also there's no data to prove this. We don't have anything to compare it with.
Okay, Rhonda?
Everything said above, but also going back to comments that we've heard over and over again, and even heard today from Angela in Oklahoma, that the insurance companies aren't always negotiating. It's sort of a take it or leave it. So I would be fearful that this could be a really low payment amount that they might be receiving. Or I'm sorry, a really high payment amount that our consumers would be having to pay.
Okay, Patricia?
Nothing additional to add.
Okay, Peter?
Nothing additional to add.
Okay, Asbel?
The only thing I would like to note is that there were several presenters as well as subject matter experts that have presented in the May meetings and subsequent subcommittee meetings around the percentage of ground ambulance providers who were out of the network, which would be really hard of coming up with some type of participating ground ambulance emergency medical environment. I think it's important to note that there is data that's come out of all claims payer databases, as well as other data that's been out there that's been recorded by the Healthcare Cost Institute, as well as Fair Health, that has painted a picture around the out-of-network ambulance services that we would get here. And this, to me, becomes really problematic in that environment of coming up with an appropriate cost share. And so where I believe recommendation or option A or B is probably the best consumer protection of giving them that number, knowing what they could possibly or potentially be liable for.
Okay, Dr. Ao?
Yes, the reason I voted no for that is that option C seems to me to be inhibiting. So for that factor, that's why I voted no. It has some characteristics of being inhibiting to the consumer. Thank you.
Okay, Suzanne?
Thank you. Most of what I want to say has been covered, but for the record, I'm just going to hit a couple key points. If we're talking about consumer protections, which this section is and this option is, then A and B, and preferably B, although I voted for both of them, are geared for all consumers, not a set of consumers that are covered under participating providers. And I also think it's worth noting, has been talked about throughout all of the months that we've met, and it came up again today, I think, in public comment, that not all is, people don't, when emergency medical services isn't like all healthcare providers that are covered under the No Surprises Act. There's the episodic nature and the emergent nature of the business puts us in a different place. And so I think that that's worth noting, as well as what drove me to vote no for C and support A and B, preferably B. Thank you.
Okay, Edward?
Yes, thank you. Everything that's been said also, reiterate the point that when someone calls 911, they're calling because of a critical event that they're having. And with how many ground ambulance providers are in a service area, you may not have ones that are in this type of supplier network. So you can't put the patient to be concerned about, do they call for help or not? And it needs to be consistent. That's all I have.
Gam?
Nothing to add. Thank you.
Okay. Gary?
Nothing to add.
Okay, I think I got everyone. Did I miss anyone?
You did miss me, Tara. So just make sure
I'm
that you know that I
sorry.
voted no. I don't have anything
Okay.
to add though.
Okay, thank you.
All right, so we are at the top of the hour. It is 4 o'clock Eastern time if you are on the East Coast, and it is ready for Halloween. And so we're going to be adjourning this meeting and we'll wrap up. But if there's anybody that has any final closing remarks, Rhonda, I see your hand is raised.
Yes, I was just wondering if tomorrow we could go back and vote on 3A, 3B, and 8A and 8B, and that way we could have a consensus that we take forward in the report. And I think that we do have that consensus. It's just not reflected because we had those additional options.
And so I'm going to defer to Shaheen on that as a matter of running the committee and taking votes. If we have the ability to go back and amend a vote, I'll defer to you, Shaheen, on that, or maybe that's something you need to research.
And Asbel, I sent you an email with the same question, actually.
Yeah, so yeah, if there are other members that feel the same way, I think, yes, we can revisit these two items tomorrow.
Okay, so we will put that as a revisit those two recommendations that have those two options, and possibly call for another vote to solidify that recommendation. Thanks for bringing that up, Rhonda. Any other further discussion before we adjourn? So tomorrow, here's what to expect, and then I'll turn it over to Shaheen for any final comments that she may have as well. But we will start at recommendation number 9. But before we get that, we will work through the construct, and PRI will come back and revisit what Rhonda and a few of the others have probably emailed that we haven't got to re-look at those recommendations and maybe take another recommendation for the record regarding that vote as well too. So it'll still be on the record. Just know we are in public meetings, so everything is on the record, but we'll go back and take another vote on that particular option as well. So just remember that everything that we are doing today is on the record. So that will be recorded in the minutes and available to the public as well. And so tomorrow we will begin at 9:30 Eastern time as well. And then we will work through the final recommendations and work through until we get to recommendation number 15. And so once we're finished with that, then we will wrap up and then tell you what to expect next and then adjourn the meeting. And so I'll turn this over to Shaheen for any final closing remarks.
Thank you, Asbel. I would like to thank all of the committee members for all the hard work that they've done. It certainly shows in the care that you've taken in crafting these recommendations. So we're at the halfway mark, we're almost there. Tomorrow we'll do the final bit. And I want to thank members of the public who provided their perspective today after the midday break. Thank you very much. And we will see everyone tomorrow morning.
Happy Halloween, trick or treat, trick or treat.